All right. Good morning. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Monday, June 2nd, 2025. The time is 10:02 a.m. We're here in the Council Room 412 for our second hearing today. We're also broadcasting live on the Zoom internet platform, on cable channel 13, as well as on my YouTube page at CMC Henderson. I'm reconvening this meeting of the Committee on Health for the second of two hearings on the FY26 proposed budget for DC Department of Behavioral Health. On Friday, May 30th, we held a hearing for public witnesses, and today we'll hear from Dr. Barbara Bazaran, director of the department, as well as members of her team. The Department of Behavioral Health, often referred to as DBH, provides prevention, intervention, and treatment services and supports for children, youth, and adults with mental and/or substance abuse disorders, including emergency psychiatric care and community-based outpatient and residential services. DBH serves eligible adults, children, and youth and their families through a network of community-based providers and government services. DBH manages the district's school-based behavioral health program and operates St. Elizabeth's Hospital, the district's inpatient psychiatric facility. On Friday, we heard from nearly 70 public witnesses, including staff, students, parents, community-based providers, and advocates. They expressed some serious concerns and offered thoughtful recommendations regarding some of the proposed funding cuts to a variety of programs, including school-based behavioral health, housing supports, crisis response, and mental health rehabilitative services. I don't see any of my colleagues who have joined today. We do have a number of hearings, and so I'm sure there'll be lots of council members who are in the building. We will get to them should they arise. But so we're going to turn right now to our government witnesses. Dr. Bazaran, before you begin, I'm going to ask that you or anyone on your team who might speak today, I'm going to go ahead and swear you in. So if you all can raise your right hand. Okay, do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth? Great. All right. When you're ready.
Good morning, Chairperson Henderson, council members, and council staff. I'm Dr. Barbara J. Bazaran, Director of the Department of Behavioral Health. With me today is Adrian Reed, Agency Fiscal Officer, and Michael Neff, Chief Operating Officer. I am pleased to testify before you today on Mayor Muriel Bowser's proposed fiscal 2026 Grow DC budget, which is focused on growing our economy, right-sizing spending, and investing in shared priorities, and how the Department of Behavioral Health supports her vision. The mayor's proposed FY26 budget for DBH ensures that residents who rely on the public behavioral health care system have access to care and supports they need to lead healthier, longer, more fulfilling lives. As a state behavioral health authority, we're responsible for addressing the behavioral health of all district residents. The proposed FY26 budget supports the transformation work underway with our partners to provide residents with an integrated, high-quality, more equitable, culturally sensitive public health system and to address the needs of all residents. It also strengthens the provider network to support enhanced quality of care. I'll now present an overview of the proposed FY26 2026 budget for DBH. The proposed FY26 gross operating budget is $378,317,166, which includes $278,098,494 from local funds. The proposed FY26 capital budget carries over about $15.5 million from FY25 for facility projects at St. Elizabeth's Hospital and the renovation of a second stabilization center. At our last budget hearing, I mentioned that DBH operated services were undergoing a review for certification by the Commission on Accreditation of Rehabilitation Facilities, or CARF. I am pleased to report that we achieved certification for all services for 3 years. This achievement was possible due to the historic investments by Mayor Bowser and the council, as well as the past mayors and council. The proposed FY26 budget maintains the investments to ensure residents eligible for the public behavioral health care system can access treatment and support services to maintain recovery. In my testimony, I will highlight proposed funding for our core mission and strategic priorities, and I can provide more detail in our discussion. In FY24, nearly 43,500 people received behavioral health treatment through DBH. Mayor Bowser's proposed budget for DBH aligns spending with service utilization and ensures that residents can get connected to the care they need by phone, at home, in school, or in the community. The proposed budget includes $44.5 million for mental health services, which will support $221.5 million in services when matched with federal dollars. In addition, the proposed budget includes $41.3 million for substance use disorders when matched with federal dollars. The proposed budget provides funding to maintain rate increases implemented with the Department of Healthcare Finance for 22 services, including 9 evidence-based practices for children and youth. I want to emphasize that we increase the rates for all clinical services to enhance the quality of care, in particular trauma-informed care, to improve outcomes. We also added clinical care coordination as a Medicaid reimbursable service, as this function is essential to whole person care to achieve optimal health. The proposed budget also reflects the savings of $11.3 million in utilization of services funded by local dollars only. These savings can be achieved primarily by managing the appropriate use of community support service and by maximizing the use of available federal benefits of Medicare recipients. Access to safe housing is essential to maintaining recovery. The proposed budget includes $29 million to support housing for about 1,700 residents, which includes $1.7 million to support rental voucher recipients who live independently. The budget reflects $1.5 million in savings by accounting for temporary vacancies in supported residents. In addition, the budget includes an enhancement of $688,000 to support operation at Wayne Place, which provides supported housing for transition-age youth. The proposed FY26 budget maintains prevention, early intervention, and treatment support for children and families at home, in school, and as needed during crisis. The proposed funding of $25.4 million for the school-based program will support all public schools with more effective use of DBH or community-based clinicians and better coordination with each school-hired behavioral health team. These teams include a school social worker, a lead teacher, a school nurse, an administrator, and a parent, led by the school behavioral health coordinator. We are now conducting an environmental scan to ensure that we are using our significant resources in the most effective way to reach students and families who need support. The proposed budget reflects a reduction of $2.3 million for support services at the 25 highest need schools and contract savings by bringing mental health training in-house. This adjustment does not affect any existing school partnerships or impact the funding of any school-based clinician. As a part of the transformation underway, we are enhancing and expanding crisis services with a trauma-informed framework. Our goal is to save lives by helping anyone experiencing a behavioral health crisis anytime, anywhere. The proposed budget includes $22.4 million for crisis services for children and adults. The crisis services are delivered by clinicians and peers at home, in public schools, and in the community by telephone and in person, anytime, day or night. The budget also includes $1.2 million reduction in the current contract for youth crisis services. We value the work of our longstanding contract partner and are taking this step to make the best use of our resources. Most crises occur in our public schools, and currently licensed clinicians are conducting risk assessments and providing support for schools impacted by tragic events. In addition, the community response team is now providing crisis services for children and youth during the evening hours and on weekends. St. Elizabeth's Hospital is the district's only adult public psychiatric hospital. The proposed FY26 budget includes $113 million, which supports 810 full-time positions, more than half of whom are in nursing. The hospital population is now back to pre-pandemic levels with an average daily census of about 270. The proposed budget includes an additional $9 million to address overtime costs within St. Elizabeth's Hospital and $770,000 to support patients with traumatic brain injury. The budget also reflects savings of $9 million achieved through vacancy savings, the elimination of five non-direct care positions, and contractual savings. The proposed FY26 budget includes $36 million in federal grants and $16 million in the opioid settlement fund to fund the district's Live Long DC plan, which supports evidence-based prevention, harm reduction, treatment, and recovery strategies to fight the opioid epidemic. The District of Columbia, led by DBH, has implemented evidence-based and nationally recognized best practices that are producing results. The Office of the Chief Medical Examiner reports that the number of opioid-related overdose deaths in 2024 decreased by 34% from the year before, and the downward trend continued during the 2 months of 2025. In addition, more than 16,000 suspected opioid overdose reversals have been reported by fire and emergency medical services and community partners. The decline in opioid-related deaths cannot be traced to a single reason, but is due to the implementation by 85 community-based and 18 government agencies partners of a combination of strategies in the Live Long DC plan. The number of opioid-related deaths is still unacceptably high. Our response is to double down on what is working and develop new strategies to get people into treatment. The proposed FY26 budget includes 4 new positions to support the induction of medication-assisted treatment in the field by fire and emergency medical services. I want to end my testimony by, as always, by recognizing the essential leadership of peers and their integration throughout the system of care supported by the proposed budget. The peer specialists now work in the provider network with treatment teams in community hospital emergency departments, our emergency care facilities, and at St. Elizabeth's Hospital. DBH funds 4 peer-operated centers. In conclusion, Mayor Bowser's proposed FY26 budget for DBH provides ongoing and new investments that support the opportunity for residents with behavioral health care needs to live longer, healthier lives. Madam Chair, we appreciate the work of the committee and look forward to our continued work to support the health and well-being of all district residents. I am ready with my team to answer any questions. Thank you for your support.
Thank you. We've been joined by Councilmember Zachary Parker, Councilmember from Ward 5 online. Councilmember Parker, did you want to provide an opening statement before we get started on questions?
Jump right into questions.
Okay, great. We'll do 10-minute rounds, and then we'll go from there if that's okay. All right. Okay, good morning. So let's jump right in. In terms of questions about the budget, the resource management line within the agency management program is proposed to be funded at $10.9 million in FY26, which is a $3 million increase. I understand that much of this increase is attributed to higher security costs. Security costs for where? Is this cybersecurity? Is this physical security? And for which location?
Respond?
Sure. We have increased security at Wayne Place, which is a program for transition-aged youth. And it was through rearranging the program, we found that we could be more effective, not including it in the contract, but to getting it through DGS and PSA. So that's the majority of our increases for security.
Okay, so it's a transfer of a contract?
Yeah.
Okay, but there's no substantial increase on the contract?
No.
Okay. All right. So I was pleased to see the proposed 1.6 million increase for behavioral health grant oversight services, particularly considering some of our prior discussions about some of the challenges DBH has had in terms of grants management around processing and overseeing specific grants. However, it appears that much of this increase stems from internal corrections, as well as the addition of a $1.8 million mental health block grant, as well as funding for one particular FTE, as opposed to a broader investment in terms of grants, strengthening grant management capacity. What investments in this budget are intended to directly improve the grants management infrastructure?
I'll have Mr. Neff talk about the details, but essentially what we're doing is we have made significant improvement in grants management. One of the things that we've done, in addition to really looking at the total process that we use and looking at where there have been issues that have resulted in delays and correcting those and providing training to staff, we are also going to bring on board Salesforce which is a platform that will help us greatly improve the time that it takes to move a grant through the process. This is something that has been a priority that we focused on. And I'll have Mr. Neff, who is responsible for this, talk about more of the details.
We have funding that was given to us 2 cycles ago for capital funds for systems transformation. And that's the money that we will use to complete an MOU with DC Health to purchase their electronics grants management system. We're excited about that because that helps us move and implement an electronic system much more quickly. It's already configured to adhere to DC and national grant standards. It has automated workflow, and we've met with them. They've demonstrated the system to us, and we use that knowledge to begin to revamp our manual system so that we can implement it more quickly.
Okay,
And
so
we anticipate that to be done in September.
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 Okay. But there was no additional money that was added to the budget for this, correct?
No, there wasn't
No.
any additional money added to the budget for it. So a part of making sure that we get the grants out the door is internally making sure that we have a system, which is the grants management system, and working with CFO, my office, to make sure that funds are loaded October 1st, so there's no delay in processing. So that budget reflects that funding that should be available on October 1st.
Okay. In terms of the org structure, I've never met this person. Do they exist in terms of a director of grants management or something in that operations, right? Like that's what you do, not a clinical person, an operations person.
Yes.
Yes,
She exists?
She does.
He or
she
she?
does.
How many folks does she have on her team?
It's Renee Evans Jackman is the director, and there are 3 staff people that support her.
Okay.
And that's in strictly grants management and the operations side. Within operations, there's also fiscal monitors that report up through fiscal services that work with subrecipients to prepare their budgets. So there's different stages. And the reason that they don't report up to the same structure is that best practice through CMS is to have those 2 areas separated, because one approves the funding and one approves the grant.
Okay. Councilmember Parker, we're having some clock issues that we didn't have during the first, but I have a timer going, so don't you worry as you see it not moving or not. Okay, I want to move to the school-based behavioral health program. So in your testimony, Dr. Bazaran, you said that the budget that you all are proposing does not directly impact any existing
Right.
folks. If I go back to what you wrote here. And that this is about being able to maximize dollars. Does this mean that we're giving up on the expansion?
No, it does not mean we're giving up on the expansion. We do have funds to pay clinicians $80,819 per school.
Sorry,
So
can you
we
repeat
have
that one
not-
more time?
So we have not given up on the expansion.
Can you say again how much the CBO grant amount is going to be for school year?
80,819.
Okay. Is the agency planning to make any changes to the funding model, expectations of Medicaid or insurance billing to be responsive to provider feedback, including feedback regarding the lack of sustainability in the current model? So for instance, our current funding model depends highly upon billing in tier 3 services. And we heard some testimony even on Friday from some providers that some schools are better at that than others, simply based on the population of the students in that building, right? You can't just make up tier 3 when the school has a need for more tier 1, tier 2. So how do we address those issues?
Well, I think that as you may remember, Madam Chair, we have actually put out some other pilots. And one of the pilots is really to look at having non-clinical staff create and do the prevention services, and having clinical staff do the intervention and treatment services. And that's one way of beginning to, expand the reach of our clinicians and be able to provide services for our young people.
So what you're describing as a new pilot.
No, that's a pilot that is one of the pilots that we looked at, if you recall.
No, but I'm saying, is that being deployed now for school year 24-25?
Yes, and Dr. Megan.
Yes, there is one school
Right.
or one CBO that is implementing with prevention specialists
Right.
currently.
That Hillcrest is doing that now.
Okay, what school is that?
The CBO is Hillcrest. I
Hillcrest
would
is
have
the
to go
school.
back and look at the actual school names.
Okay.
I can get that too.
Was this one CBO the only one who responded to the application?
That's correct. Mhm.
Okay. Is it working?
Again, I think it's a small group. I think there is some benefits, obviously, to providing those prevention services by an unlicensed clinician. And so, again, very small sample and looking at it, but we do have some data to show that's effective.
Okay. I am, so I'm pushing here because I have data that shows that under the existing model, right? If I don't do any of the pilots, none of the others, you gotta bill at least $33,000 in Medicaid to make the model work. But most of our schools are barely cracking 15 grand. Is that accurate? I just wanna make, are we operating from the same set of facts on that? Or do you feel differently about the billing?
I think the billing, as you said, there's a wide range, right? I think there's some agencies that are very efficient in the billing. In order to be able to bill, you obviously have to have an accurate caseload. And I think, our benchmark is around 15. And so without reading that benchmark of 15 caseload, it's hard to bill and get reimbursement for those services. So I think one of the things that we need to do is make sure that the clinicians in each of the schools has the caseload that we're looking at. And we're not at that point yet. And so our oversight and monitoring, we need to make sure that they're meeting that benchmark.
Okay, I think I'm over my time, so I'm gonna go to Councilmember Parker. We're gonna come back to this and dig a little bit more. Councilmember Parker?
Thank you. I'm going to continue on the same vein. With the $2.3 million reduction in the school-based behavioral health program, part of that is framed as savings because you're bringing mental health services in-house. Can you elaborate what exactly you mean by that?
Yes, thank you for that question. Cognito is a provider that was operating training for all of the school staff. And we are bringing, that was around suicide prevention and intervention, and they literally went out of business. And so what we are doing is bringing that in-house, and we do plan to develop a module that will be online and available for all schools.
And so that sounds like that's a work in progress, but so that $2.3 million largely you're saying is because that training from that company that went out of business will now be done by DBH?
No, there are two pieces of that decrease. One is for Cognito, which I think is 499, and then there's a 1.8 million reduction for the 25 highest need schools. The Cognito service, as I said, they literally went out of business, and we will create that training. And so we're bringing that in-house. And then we also did decrease the amount for the 25 highest need schools. What we found is that the schools had difficulty spending the money. There were lots of challenges, and this is in addition to the money that's allocated for the school-based clinician. And Dr., I don't know if you want to say anything else.
Turn your mic on.
Sorry. That 2.3 million cut makes up the 1.8 from the 25 highest needs and then the $500 from the
Right.
Cognito contract.
And can you elaborate on why the highest need schools were struggling to spend down the fund?
There's a variety of different reasons. Some that those funds go through the CBOs. And so there's some reports that there's an administrative burden to spend those additional $70,000. So it's extra support that's needed to provide those. In addition, there's some schools that did not have, were not matched with the CBO, so could not spend the funds. So there's a lot of different reasons. And so as Dr. Bazran mentioned, it's about 700,000 that's unspent right now to
And
date.
how much of that would you argue is the responsibility of DBH in terms of getting payments out and working with the CBO in terms of management?
Sure. Well, those funds are actually, the CBO has them. And
Right.
so they were given out, and actually this fiscal year, our grants management, the NOGAs and how we get the money out were all sent in October and November. And so those funds are with the CBOs.
Right.
Again, the challenges are kind of in those subsequent activities after that.
Right.
And so
So they had the money. Oh, and the clock is working. Great. They had the money. But what can you speak to, and maybe this is for the director, the management checking in with CBOs to say, hey, we're seeing you're not spending down the funds, or can you let us know the services that you're providing? What does that look
Yeah,
like?
we actually, within our school-based behavioral health team, we do check in with the CBOs on their spending and their billing, and encourage them to bill appropriately, and also to track their spending, and whatever services and supports we can provide, we do. But I just want to emphasize the fact that the CBOs get this money upfront. And so then they have the ability to distribute these funds as needed to the schools. And so it is not an internal grants management issue.
And like we've heard with other agencies, I'm assuming the framing here is we can expect a similar level and quality of service, but you've identified savings, and so that is what's accounting for that $1.8 million reduction. Is that fair?
yes, and I would
Yes.
say again, just to reiterate again, these funds are separate than the funds that are going directly to support and pay for the clinicians in the building. So these were additional funds that were given to these 25 highest need schools.
Understood. I did want to come to the reduction in crisis services. Director, can you elaborate what exactly is being reduced with this line item, as that's another significant drop in funding?
Mhm.
Sure. In regards to the youth crisis services cut, it shows $1.2 million cut. There is, an additional funds within that contract. So it's about $617,000 that are continue to be on that contract. And so, as was mentioned earlier, we really hold true to our partnership with CHAMPS. But one of the pillars that we worked on was really looking at quality of services as well as efficiencies within our services. And so, this is one of the areas where you likely all know this, but during the day, about over 50% of the calls to CHAMPS are from schools. And so, as you know, we have licensed clinicians in our buildings as well. And so essentially, we're paying for funds for clinicians in the school as well as CHAMP staff coming into the schools. And so all the licensed clinicians, again, they're licensed. And so they have the ability and clinical ability to do risk assessments and should be doing risk assessments on the youth in the schools. And so in some areas, we see this as, again, almost like there's two people, right, who are doing the same service. And so this is an area where we can see we can be more efficient. And so we plan to work with our partner CHAMPS as well as our school entities and educators, and we already have. As well
Jumping in
as
here. So the argument here is, well, the majority of incidents are happening in the school day, and we believe we could be more efficient by working with school-based clinicians to support young people. Is that fair?
Partly fair, yes. And I would also add that we've already begun with our educational partners to provide additional support and training around risk assessment. It's not to
But
say
what
that,
about incidents outside of school? So let's say we can
right.
see that, yes, there were some redundancies in the school-based environments, but what about what we're seeing play out on the news in the evenings, but just also community-based needs? How are those going to be met with this reduction of $1.2 million?
Absolutely. I think that's the collaboration between ourselves, CHAMPS, obviously they have remaining money on their contract, as well as our CRT and crisis services within DBH. So that's going to be a collaboration between all of us to ensure that those crises and those phone calls, whether they're from home or whether church or somewhere that's not in the school building, we're able to respond appropriately.
And can you speak to the magnitude of the impact of the cut? So, yes, $1.2 million drop, but what does that mean? Can you contextualize it for me in terms of service hours and or how do we make sense of what that impact will mean for community-based care?
I can speak to
Yeah.
what happens between, as you know, CHAMPS provides services from 8 a.m. to 8 p.m. And one of the things that they shared with us is that the overnight hours, they had a clinician sitting there, and in many instances, the clinician did not have anything, any to respond to. So in FY24, for example, if you look at the entire year and you look at what responses were needed, there were 261 emergencies that happened during those overnight hours, and only 77 required a deployment. So if you look at that, it's 21 per month, or 5 deployments per day, having a full-time person sit there. If you look at this year, there have been in Q1, Q2, 82 instances in which that has happened, or about 13 a month. And if you look at, and 33 deployments, and so if you look at that, then it's even less. And so we're trying to really be more efficient with our use, and we plan to be in partnership. No one agency nor organization can do this alone. And so we are definitely working in partnership with CHAMPS, with the school-based teams that are already there, and then also the Department of Behavioral Health has a crisis team that is often called out to address issues that happen around schools, a school shooting, a death of a young person, a death of a teacher, or so forth.
Understood. I am over time. Chairperson Henderson, I do have to run to a ribbon cutting and I'll come back. I would just say, Director, given the significant needs of young people, I challenge the notion that there isn't a need for these crisis and intervention services. And I wonder what you're referencing in by number is more about utilization, which is different than need. And how do we socialize that these resources are available would be the angle that I would pursue. But thank you for your testimony, and I hope to jump back.
Councilmember Parker, before you go, I just want to clear something up. So you continue to say in your testimony that there's money left on the CHAMPS contract. I think you said like 600,000. We don't see that anywhere.
Yes.
We see 135,000.
No, that's a mistake.
Okay, so where are we going to get the extra money? Because the documents that we have in the data dump are not showing $600,000 anywhere. In fact, CHAMPS believes they have been cut.
Yeah. No, there is money left on the contract. There's $616,000.
We're showing
left on the
$135,000
Our
proposed.
agency fiscal officer can address that.
So what we need to do is update one of the to be determined lines and move that money to the CHAMPS contract and resubmit.
Okay, they were like 6 to be determined lines, which makes it really hard for us over here. Because I would cut a to be determined.
We understand.
Okay, now, so on that, in terms of the partnership piece, Dr. Bazaran, you said you're talking about the partnership, but we were the ones who had to tell CHAMPS that their contract was being reduced. You guys didn't give them the heads up. They didn't even know to come to testify. to tell us a little bit about it. So I'm concerned about that. I'm also concerned, you said that during the day, over 50% are coming from schools. Did we give any notice to the education cluster that we would be cutting this support for during the day? Because what they did prior to CHAMPS was they called 911. This is not just about students who are dealing with trauma and other things. You know this. This was about students who they were heightened in terms of, right, like could not be calmed down. They did not want to do physical restraint. So do the schools know that they're now going to just be encouraged to handle the student again?
Well, I can say that I've worked with the trauma teams in a number of the schools when things have happened in school that require, that are crises that need to be addressed. And they have teams and staff there who are poised to provide that service and do provide that service in partnership with the school-based behavioral health clinicians in the schools. And if additional support is needed, our team that's housed at our office will go in and also help.
Okay, you also said that, oh, they'll use the school-based clinicians that are on staff. How many schools don't have a clinician right now?
I'm sorry, I will give you that number. We have a total right now of 148 schools that are staffed with clinicians.
So how many does that leave who does not have one?
I'm sorry,
How many have not been matched?
that's 58% of the 254.
Okay, so the other 48%, not 48, 42.
42%.
I've been doing a lot of math on today. The other 42% who don't have a clinician, who are they supposed to call when they have a student in crisis
Well,
under this model?
I will add that as we've talked about before, it's not just the DBH funded CBO clinicians and the DBH clinicians. We are committed to working as a team, behavioral health. And when you asked if we've been communicating, we have been partnering with our education partners around risk assessment specifically and providing training. They're providing training, and as well as DBH will be providing additional support over the summer. And so again, we plan to work in partnership with all of these entities to ensure that people feel comfortable doing this and knowing where, if, for example, there is a vacancy in the building, what are those steps, right? And how do they get the support that they need to help support the youth in their building?
Okay, so it sounds like you're going to work on a plan over the summer. That's what it sounds like to me.
The training has already started and there is a plan to help train. There's over 100 that have already been trained, and we will continue to train over the summer, as you know, because that's the time where we provide the most support to our social workers as well as our educators. And so we will continue to roll out those risk assessment trainings to help support. So when they're back in
Okay.
September.
So under the current CHAMPS contract, they provide services from 8 a.m. to 8 p.m.
Mhm.
With more than half a reduction, what will be the expectation of when they provide services?
I think as obviously with the reduction in cut, we will have to go back and make a modification to their contract. And so those specifics will be part of that modification.
Okay,
Mhm.
what are you envisioning in terms of time?
Again, I think we
I'm
need,
asking these questions because if I'm going to put the money back, I need to know.
right. I think that what we're envisioning is their peak hours we know are from 11 to 3. And so they'll be supported and those teams will be fully functioning at those times. Where we provide support, obviously, will be within the school-based program and those clinicians. And I think we see fewer calls after 3.
Right, and I'd also like to share, Madam Chair, that they also do bill for crisis services, and crisis services is one of the services in which we increase the rate. And they are getting certainly additional funding. I think it's a little bit more than, 20 to 25,000 in that.
Okay. In terms of the reduction on the CBO grants, so I obviously heard the back and forth that you had with Councilmember Parker. You said that the bulk of this on the 1.8 was from the additional 70,000, so not including the other piece from the high need schools. I feel like we've been talking for a number of years on the cost of the grant, how much in the grant. So it's a little surprising that you all are not at all even considering an increase into the grant amount, even with inflation. Like, there's not even a COLA. What is the apprehension towards increasing the grant amount for the schools that you have been unable to pair for 3 or 4 years now?
What is the apprehension for increasing the grant for?
There are schools who you have persistently had challenges matching with a CBO, which that could be for any number of reasons. But when we talk to CBOs, they say the number one reason that they're not choosing to bid on these contracts or apply is because the grant amount is too low. Well, in the good times, well, not the good times, it was bad. It was pandemic, it was bad. But you had money. You all increased the grant amount. And then that money went away, but we're not even like thinking about retention or recruitment from the perspective of using the grant award as an enticing factor.
Well, we are really committed to continuing to work to have resources to support every school. And we realize that we have to do some different things in order to get services in those schools, which is why we are really advertising and soliciting for the various models that are different, things like telehealth and so forth. And another thing that we are doing this year is we will enter into a telehealth contract so that young people in those other schools will be able to get services through telehealth.
Okay.
We also have, chat and text functions in 988, and we're seeing that young people also are using those services and getting supports and getting connected to care.
Okay, so what if we do the thing that the CBOs have been asking, which is to acknowledge that we can't do every school right now, and take the money for those schools that have been persistently vacant to increase the grant amount for the schools that have a clinician? Why won't we do that?
Well, here again, my concern would be that there would not be any funds available for the remaining schools.
But you
And
just
then-
said that
and
you
then
have
the
folks
set-
at DBH who
excuse
can
me.
fill in.
And then the other thing is then next year, then we will have even fewer opportunities to provide services for those additional schools.
But you said that if there's a need that arises, you have folks at DBH who can help and assist with schools.
But our goal and the mayor's goal is that we can have a clinician in every school.
I know, but we've had that same goal for how many years and we've never reached it. So can't we acknowledge that perhaps we expanded too quickly? Did we not, we added funding to do it for everybody, but we haven't been able to reach it for everybody. And it's kind of you're putting us in a tension spot because I have money that I know is not going to be spent. And I have schools who have people who are trying to make it work and they want to stay, but the pay is just so low. Do we not owe it to try to hold on to the people that we already have as opposed to holding on to a goal that we haven't reached in 5 years?
I would just add that it's also important to look at the quality of services, and we know from the COVID funds that just by adding the additional funds, it does not retain the staff. And so our mission and our goal is to look at quality of services as well as to provide services in all of the schools. And so right now, as you know, we're at about 60%. So we're providing services and supports to about 60,000 youth, right? If we go and support and pay the extended amount, we will be servicing fewer kids, and still the quality is not where we need it to be.
How would you be servicing fewer kids?
Because
We're not proposing to cut from anybody who has something already. These are vacant, been vacant. CBO has never been able to match.
we're not able to provide the other supplemental, we wouldn't be able to do telehealth, we wouldn't be able to do the other things.
Okay, so how many CBOs are doing the telehealth pilot?
We're talking about putting out an
Contract.
additional RFA.
Okay, so we have not put that out yet. Okay, let's talk about the charter school one. How many are currently in that pilot? Which, to be clear, y'all didn't want to do. We had to push. This is why I'm pushing to do something different, because you didn't even want to do the pilots that we already have in place that we had to push for.
We have 8 charters and in our CB, in our LEA pilot.
Okay, so we have 8 charters in the CBO
Yes.
pilot. We have the telehealth pilot that's coming online for 25-26.
And the hybrid telework model, and we have 3 CBOs that are working on that.
Okay. When a CBO signs up for one of the pilots, are they also committing to being fully staffed in that model? i.e., do you have CBOs who apply for a pilot, but they still don't have somebody for those positions?
Yeah.
Yes,
Sorry, but which part? Yes, that they don't have somebody, or that
it's
they,
possible they don't have someone. When they apply, you mean when they apply for the RFA? They don't currently usually have the staff member until they receive the award, and then they would receive the grant funding and hire.
okay, so then my question is, for the 3 hybrid telehealth folks, are we sure all 3 have people? The 3 who applied and are currently operating for school year 25-26, do they have vacancies?
One has a vacancy.
Okay,
It's a recent vacancy.
okay, and for
Yeah.
the 8 charters, do they have vacancies?
No, there are 8, there were a total of 10 who applied, and there are 8 that currently have staff.
Okay, do y'all want to ask each other? Because she's shaking her head, something different. Because that performance oversight, 6 had a vacancy. You had 8 schools, 6 had a vacancy.
2 are currently staffed.
2,
Mhm.
okay. So that was pretty much the same from March. Okay. And then is there something beyond the 3 pilots? So we've got telehealth hybrid, we have the charter, and then there's a third one that the application goes out for.
And then you have the hybrid, which is having somebody work on-site 3 days a week and 2 days virtually.
Okay, so the new pilot will just be telehealth only. Okay.
And the only addition I would add is what we talked about before, where Hillcrest is providing those prevention specialists. We aren't necessarily calling it a pilot, but
Okay. The school-based behavioral health line, budget line also includes about $325,000 for early childhood grants. Which program is this? Is this Peace? Is this Healthy Futures?
Yeah.
Which one is
Healthy
this?
Futures is fully funded. Our Healthy Futures program is fully funded, and those funds are for that program for Healthy Futures. There are additional funds that are available for the Peace Project, and I'll get you the specific number for that.
Okay, here's the confusion for us. In your budget, you have a separate line for early childhood services, but then in the school-based behavioral health line, you have a line for early childhood grants. They can't all be for this, maybe they are, but then this is a duplication. So that's why we're trying to figure out who's for who. In early childhood services, I imagine those are that might be your Healthy Futures money. And then you have a grant. What's the grant for?
There are no grants in Healthy Futures. They're all FTEs.
Okay.
And so they're all employees. And so any funds, any additional NPS funds for Healthy Futures would be contracts. We
Okay.
don't do sub-grants for Healthy Futures.
Okay.
Yes, for
So
P,
in the grant, contracts and grant spreadsheet, and maybe Adrian, you can help us with this. There's a grant, it says school-based grants, and then in the grant purpose, it says early childhood. 325,000. That's what we're trying to figure out. What is that for?
I think we need to get back to you on that so
Okay.
that we can follow up with that.
Okay.
right, because in the Peace Program, which are FTEs, there's 1,661,000 in funds to support the 9 staff that are there. And that's all staff.
Okay. All right. I was glad to hear that the agency is conducting an environmental scan for the school-based behavioral health program to ensure that the agency is using resources effectively. What is included in this environmental scan? How long is it gonna take?
Mhm.
Go
Go
ahead.
ahead.
We just concluded all of the interviews. So our current staff reached out to coordinators, scheduled interviews with each of the 254 coordinators, looking at things that we've been talking about for a long time. Who's in the building, not just DBH funded staff, but school staff. Who are you providing services to? So special ed, regular gen ed, as well as are you full-time, part-time, and who's the funding? As well as are there outside partnerships? And as it's named, we're really trying to get a landscape of what's going on in the building and which behavioral health providers are there.
Yeah, okay, which is good. I wish we had done this before, but it's helpful. And I think even just sort of even going down a little further, we had one of the therapists from Mary Center testify last week, and she talked about how, yes, there are other people in the building, but she's the only one who does the group and individual therapy, which I think is very specific than someone who is I have the title of school psychologist, but I don't actually do that type of specific work. When do you anticipate being able to wrap it up?
It's wrapped up.
Well, I mean, your interviews are wrapped up. A product for which people can view.
We to be honest, we need this data to help us move forward and make some decisions. So we anticipate are we in June? June.
Mhm.
The end.
Yes, welcome to June.
June.
Okay. On that, so we've moved faster on the environmental scan. The cost study for school-based behavioral health, I feel like we've been talking about this for 3 years. Where is it? Who's got it?
It's still under review
With whom? You?
with us, yes.
So it hasn't gone over to the mayor's office yet.
It's still under review, yes.
I think somebody's trying to get your attention.
Oh, sorry.
All right, I'm gonna move on to the community response team CHAMPS Access Helpline. So the proposed FY26 budget for Access Helpline is 4.4 million. It's reflecting a 1.8 million increase, including 4 additional FTEs. What's the breakdown of that $1.8 million increase for Access Helpline? Are these new people?
The $1.8 million breakdown, so the budget formulation process allows us to estimate the projected grant funds that we'll have in any given fiscal year.
Mhm.
In the past, that estimation wasn't including the Access Helpline grants because we didn't know that we would receive those grants for recurring years. So it's not new funding, it's just funding that's loaded so that it can be available on October 1st, so that there are no delays in services. The
Okay.
increase in FTEs are incumbents that were hired to work on the federal project so that we can spend those funds down.
Okay, all right. So the Access Helpline team is still, I think, how many did we have it before? 8? Is it still 8, the Access Helpline team?
26.
26. Okay. All right, can we break down who the 26 are?
Yes.
So my question, I mean, we call it the Access Helpline team, but I know there's folks who do Access Helpline, 988, and then other types of activities. 26, well, no, let's break it down today, because I think I have OUC later this week, and then I don't want to have the wheel turning again. We have 26 people. Access Helpline is 24/7. How many people are working per shift? I'm looking at Adrian, but I know you don't have that answer, so let's call a friend.
Oh, and the other thing too, Madam Chair, I just learned that the school-based report was just transmitted to council.
To us?
It was just transmitted to council. It was sent to the office of the secretary.
Okay.
Okay?
All right. If you just introduce yourself for the record. Oh, got to turn your mic on.
Good morning. I'm Bernadette Boozer. I'm the interim chief for crisis services.
Okay.
And I'm the acting director for the Access Helpline.
Okay. All right. So we have 26 on the Access Helpline. How many are on per shift? Or is it shift?
So it is shift.
Okay.
So the total where you get the additional staff it's a total of 30.
Okay.
We have 8 dedicated staff specifically to 988 services,
Okay.
with that leaving a remaining of 22 staff that provide other services within Access Helpline, to include responding to 911 calls, warm line calls,
Okay.
and other special initiatives.
Okay. How many are on per shift?
On average, it's 8.
Okay. And a combination between the
Correct.
988 people and.
Correct.
Okay. Do you have some of the similar issues that some of our other agencies who have overnight shifts have in terms of call outs and staffing?
We do.
Mhm.
We
Okay.
do.
How often are you not at your 8? Or is 8 your,
8 is fully staffed
okay.
Mhm.
How often are you not at 8?
in a given week, once or twice.
Okay.
Mhm.
Okay. So Access Helpline currently relies on annual federal grant funding to help support the key operations. In these times, federal funding is unstable at best. And we're already starting to see some early signs of reductions around 988 from the current administration. It could very well be eliminated or otherwise. Do we have a contingency plan in terms of continuing to sustain Access Helpline operations in the absence of federal funding?
I would have to defer to Adrian.
Well, first of all, I think one of the things about our Access Helpline that some of the other states don't enjoy is that we had an infrastructure to begin with. And we had staff in Access Helpline who could answer the phones. And right now, those individuals are cross-trained. And so if something should happen and we did lose some funding, then we would have to then use the staff that we have in order to provide those services.
Okay. For the proposed budget for the community response team, it reflects about a 798,000 decrease with a loss of 2 FTEs, which is a bit surprising because we've been pushing for deeper investment on crisis response. My understanding is that the decrease is attributable to moving 2 FTEs to the Access Helpline federal project. Is that accurate?
That's accurate. Yes.
Okay, and so now the NPS decrease is due to a pharmacy contract with 35 K Street.
Mhm.
Can you say more about that?
We provide, one of the things that we've seen is that utilization in terms of our pharmacy at 35 K Street has decreased. And the reason it's been decreased is because more than 90% of the individuals who are in the public behavioral health care system do have insurance. And so they have the ability to go to CVS or whatever pharmacy they choose.
Okay, all right, so how much was the pharmacy part? I just want to make sure my math is right.
The decrease in the pharmacy contract was 126K.
Okay. Okay, so beyond this, there were no other changes to CRT.
There weren't.
Okay,
No.
all right, okay. Let's move on to mental health rehabilitative services. Okay, so the proposed FY 26 budget includes an $11.3 million reduction in local funding for mental health rehab services. My understanding is that this is the local, so not the federal match, this is the local side. And my understanding is that most of the reduction results were from changes to community support services, which is a policy change, a reduction of authorizations to 100 units per 180 days. Now, I've had to learn with lots of conversations with the community. We use a lot of acronyms in the health field, and we also talk about things in other ways. So we're going to break it down for just a second.
Okay.
Community support services. What does that mean?
Community support services are designed to help people with activities of daily living and the care coordination and connection to other services within the system.
Okay, so if I went to a CBO under this, is it therapy services? Is it something else? What would I be getting?
Therapy services, as you know, we have 22 new services that are now in our SPA, and those are clinical services. And one of the things that we are doing is moving our service system to more of a clinical model, as opposed to simply looking at activities of daily living. That's a part of it, but also people need to get better. And to get better, they need therapeutic services. So we now have care coordination, we have targeted case management, also we have crisis services and a whole array of evidence-based practices. And so some individuals, like for example, when people need large numbers of community support service, that means they have greater needs in terms of their mental health services and supports, and they need to be in a clinical service as opposed to community support.
Okay, all right, so I did math this morning. I had to use algebra. All right, so the new policy, 100 units per 180 days, which is 6 months for those at home. 4 units equals an hour. Is that
That's
accurate?
correct.
Okay, all right, so that means that a person could do 25 hours per 6 months.
That's right.
All right, which means an hour a week.
That's right, but they also can use care coordination, intensive care coordination, or targeted case management.
Okay, last year when we were here, you all had made a
Clinical care
policy
coordination.
change to reduce from 600 units
To 200.
to 200 units. And now this year, we're going from 200 to 100.
Right.
What changed in a year?
Here again, we're moving the service system to more of a clinical model so people can get better. And what we're finding, if you look at some of the assessments that we routinely do for individuals, we're finding that their needs are greater than what can simply be met by community support.
Okay, so let's walk through this as though I'm a person in need of care who had been using 200 units. When I go in to my CBO for care coordination, what would they say to me? We actually think that you need to increase your clinical hours as opposed to being here with us?
No, it starts with the treatment plan. And so if I am the person that's working with that individual, I have a treatment plan that says what they need. And I need to build into that treatment plan what services can support them in moving into recovery. And we got to use the full array of services and not simply just community support, because that really does not provide for the needs of the individual.
Okay, based on the data and you all making this decision, was it a feeling like these individuals who were using community support were not using enough on the clinical side, and therefore this was like a push?
The number of the usage and utilization of clinical services really has decreased as opposed to increasing.
Okay, what was the process to pick 100 as opposed to 150, 160, 180?
We looked at the needs of the individuals. We looked at the assessment data. And here again, we really want to move people to a more clinically driven model. And, you might note that, in other places around the country, many of the country states don't even use community support as a service.
Okay, the reason I'm sort of asking this is because I'm trying to figure out like where the basis came from, because it's 2 years in a row, we're dropping units, right? And I want to make sure that this wasn't driven by a budget, but this was actually
No.
driven by
No.
a clinical need. And in some cases, though, I would expect you to say, we looked at the data and 98% of our people were only using 100 or using 98 hours, and therefore we felt comfortable with this change. Did that type of analysis happen?
Go ahead.
I would like to point out, as you look at that number of 11.3, that 9.259 belongs in the match. It was inadvertently placed in local and should have been in match. So what you're seeing is that reduction, which is on the clinicals, is on the match side. It's because it was one-time funding, and that was why it was reduced. The reduction on the local side is $2 million.
Okay, that's helpful to clear up, but that doesn't change the implications of the policy change. So based on the DBH data that we have, only 36% of individuals use 100 or few units per 80 days, 180 days. 36. So that means that the vast majority of people have been using over 100. And so this is a shift.
It is a shift.
And it's a shift for providers. And
yes,
are you going to come back next year and ask for 50? Like, are we phasing out? Let's just be honest with people. Is the intention to phase out community support services?
We will look at the data and make that determination based on our experience.
Okay, if you introduce yourself for the record.
Good morning. My name is Atia Jackson. I'm the Senior Deputy Director at the Department of Behavioral Health.
Okay. I didn't know if you wanted to add something to the
Community support, yeah.
I would echo what the director said, that through data that we've looked at, there has been a shift in the utilization of the non-clinical support service of community support over the last 5 years. We have shared that data with providers, and we're working to ensure that district residents who need behavioral health service can get the best service. And while community support has increased in utilization, as the director said, we saw a corresponding decrease in other clinical services. And some of the services that the director mentioned, there are others. You started out with your example about counseling. Counseling and therapy are not community support. A core service agency, you said we talk about a lot of acronyms. CBO is what we're talking about, a community-based organization on the school-based side, because as you know, some of those providers are not also DBH certified.
Right.
On the MHRS side, we have core services agencies. And those core service agencies are certified to provide 4 core services: medication somatic, community support, counseling, and therapy, and diagnostic assessment. So if I, Atia, am receiving services from Adrian's CSA, they're treating the whole person.
Yeah.
I'm not just going there for community support. I should be seeing a psychiatrist there, a therapist or counselor who is licensed, like a licensed professional counselor, a licensed clinical social worker, a licensed psychologist. The community support worker is an unlicensed type
Person, right.
It is akin to a, like someone who is providing, as she said, activities of daily living. It is not intended to be undergirding of my care.
Mhm.
as a
Okay, not your
consumer.
main person.
That's right.
It can be my main person in terms of the case management.
The coordination, but not your main
clinical
person
care.
for support.
Clinical care.
Correct.
Mhm.
Okay, thank you,
Welcome.
Dr. Jackson. I think that was super helpful. I don't think that alleviates the concern of providers that the change is happening so quickly. To go from 600 to 200 to 100 in 2 years.
Mhm.
So I guess I'm trying to understand, one, what is the conversation that you all have with providers around preparation for this particular type of step down?
Mhm.
Because to be honest, and I know you guys are in your behavioral health lane, I got other agencies who are doing similar step down pieces, but I feel like their providers are more well informed to know that it's coming. And
Mhm.
this one sounded like it was like how you doing? We're gonna change you again.
We spent a lot of time this year really talking with providers around the step down from to 200. And we do plan and will do the same thing in terms of the step down from 200 to 100 in the beginning of the next fiscal year. We have just begun those conversations recently, just begun them. And so it's a process that we have to look at.
Okay, how would you respond to the testimony that even though in this new policy, you all state if someone needs additional, they can make that request,
Mhm.
but that their experience in this year of 200 is that less than 5% of their requests for waivers for increased services have actually been granted?
I can respond to that. DBH, Dr. Bazran meets with providers in person each month.
Mhm.
And at our last in-person meeting, we responded directly to the concerns about the supplemental units.
Right.
We found that there was actually a technical error in the system, which was causing many of the requests for supplemental units to not land, just for a technical issue where we needed.
So to not land, to not even arrive to you.
Yeah. So we have to
Interesting.
create new secure user accounts, which is happening right now.
Right.
And the plan is to restart that system once all those secure unit accounts are created. And I believe the date that I shared with the providers was by June 15th. That should be up and running again.
Okay.
Yeah, so it was greatly a technical issue.
Okay. Now the waiver process, that's on a case-by-case basis, or is there a particular standard?
Mhm.
It's a
Yes.
particular standard. So under Dr. Boozer's shop and Access Helpline, those are where the requests for supplemental units of community support come in. The requesting provider has to include a brief narrative justification of that clinical request, why the resident needs more that they're serving, and they have to include treatment plans, and they have to include a patient choice form.
Okay. Okay. And this process will continue under the new standard?
It should for a certain amount of time, because as you mentioned, there's a lot of change. So we don't want to abruptly end one service as we put in place another authorization process for those services. There could be
Okay.
some overlap.
In your analysis, in terms of clinical versus community, were there certain CSAs that you felt it was more egregious than others?
I cannot say that.
Okay. All right. I'm going to go to the stabilization center. So there's 8 million in capital funds allocated for the second stabilization center. Is there funding? Now, maybe I missed it, but is there operations funding in FY26 to operate this second stabilization center? My understanding in terms of the timeline is that the second stabilization center was supposed to be completed around this time next year, which would be in the middle of FY26-ish, but there's no money to operate it. At least I'm seeing, unless it's hidden somewhere.
Well, not hidden, but the current stabilization center has been very successful and very, very successful in being able to bill for the services. And so part of our plan is that we're not going to have more than a quarter that we need to fund up a contract. If we did, it would be startup money before they're completely able to cover all their costs now by billing Medicaid for services. So that we would do the same thing. We would find it within to do a short-term contract, and we plan on submitting a enhancement request for 27.
Okay, but on that timeline of a 27, let's back up. When do you anticipate construction to be complete on place number 2?
At the earliest, probably the last quarter. Right.
It's actually about a month behind.
Right, because they're a little bit behind now in terms.
Okay, so it won't be done, I guess, until FY 27. Okay. Alrighty. Is there any well, they're behind schedule, but are they over budget? I just gotta ask in the.
Not on the
No.
capital side.
No.
Okay. All right. So the proposed FY 26 budget, once again, eliminates the funding for the court urgent care clinic, which provides, on-site behavioral health services at DC Superior Court. I visited the clinic, sat with some judges, and I continue to hear strong support for the work, specifically from those who are closest to it. Judges, the court staff, the U.S. Attorney's Office, the Public Defender Service, even the DBH staff that you all detail to the drug court and other things, all who have praised the clinic's role in stabilizing individuals and connecting them to care in a very stressful situation. The only people who seem not to be convinced is DBH's central office staff. So why are we eliminating this again, even though everybody else says this is needed?
First of all, one of the things I'd like to share is that I have met and talked with the chief judge about the urgent care clinic. As you know, one-time funding was put into our budget to continue it during this fiscal year. I have asked the judge whether or not there was any ability for the court to contribute any funding, and they have indicated that they could not do that. And so we do not have funding to support this. However, we do want to make sure that people who are in need of services get the services they need, and we have a plan for that. And so I'm going to turn it to Dr. Chad Tilbrook, who is responsible for oversight of the urgent care clinic.
Good morning. Dr. Chad Tilbrook, Director of the Forensic Service Division at DBH. As the director stated, yes, we did approach our partners, our judicial partners, and spoke with Chief Judge Lee in November and in February this year, prior to the continuing resolution decision by the federal government. And so we did request support, financial support from the court for the continuation of that clinic. As you heard on Friday, it is a clinic that is widely utilized and is successful. We have discussed with our partners that we are unable to continue funding that service, but we have provided them with an alternative solution. All of our partners know that they can utilize the services at 35 K Street, our core urgent care clinic, which provides diagnostic services, psychiatric services, counseling services, SUD services. But in addition to the services at the core urgent care clinic, they can also receive nursing and pharmacy services at 35K, whereas those services are not provided at the core urgent care clinic. The two biggest utilizers of the core urgent care clinic are CSOSA and pretrial services, not the court. The court averages low single digits per month, whereas the CSOSA and pretrial services, our federal partners, they average about 30 to 45 individuals per month. So we can easily accommodate and meet their needs at 35 K Street.
If 35 K Street were across the street from the court, maybe. But who is going to leave Superior Court know where Superior Court is, and take a bus or a train or whatever to get to 35 K Street when they are in need of urgent connection. I would just go home, respectfully. The part of why it works is because it's located right there. You can't, like, somebody either walks you over from CSOSA or you're coming down straight from the courthouse or a courtroom or whatnot. But like, to say your alternative is to, like, if you just go to 35 K Street, they can help you there. That doesn't bring sort of the connection together. And I appreciate that you all met with the chief judge to have this conversation, but what about this administration did you think that they would want to invest in this? If they had their druthers, the DC Superior Court wouldn't exist. Everybody would just be going through feds. So I am, did you guys even ask the mayor as an enhancement? I mean, I have other agencies in the health cluster who saw cuts in other places, but then they got plus ups. And frankly, it's interesting that DBH had none. The plus ups that are reflected in the budget are just moving money around. There's no new programs, no new enhancements that I'm seeing, unless I'm missing something. Okay. Let's talk opioid abatement. Thank you. Okay, so the proposed budget includes 36 million in federal funding through SOAR and Live Long DC, in addition to the opioid abatement settlement funds. I noted that there are no specific local funds budgeted for opioid response. Is that correct?
That's correct.
When's the last time that we funded any local funds on opioid response?
I view the budget as early as 2023 because that's just when I entered the agency. So, and I didn't see any opioid funding budgeted there under local funds. So I'll defer to Dr. Basron to talk about any.
Yeah, it was SOAR funding. We've used SOAR funding to support our Live Long DC plan and also the opioid abatement fund.
Okay, and this is a sort of similar question because SAMHSA's been on the cut list for a variety of these federal folks. And one of the things that we're thinking about in terms of this budget is, are we building a budget for FY26 that can sustain federal cuts and blows? If our entire opioid operation is based on either settlement funds or federal funds, that makes me nervous, because if the federal funds go away, that means I only have settlement funds left.
Well, one of the things that I will share is that we do have a range of services and supports that are locally funded. Those are the services and supports that are within our state plan amendment. And you may recall that we worked to get substance use disorder services in the state plan. It was not there before. And so before, all of those services were either block grant funded or SOAR funded. Now we've moved that, and that includes a full range of clinical services using the ASAM criteria, and also looking at things like environmental stability and other support services. And so if it all goes away, people can still get substance use disorder services.
Sort of, because
I mean, we don't want it to go away.
No, but like nationally, 47% of people who are receiving SUD treatment are on Medicaid. What were they trying to cut? Medicaid. I'm trying, this is not your fault, obviously, what's happening on the federal side, but I'm trying to say, like, what are we putting in place that should something go left, the bottom doesn't fall out in terms of all the work that we have made and all the progress that we have done on this. And so even just a little, I don't know, a rainy day fund for us to be able to continue on. That's what I would love, that we are sort of thinking in that way of, like, what happens if Medicaid is cut? Because all of the folks you were just talking about getting the treatment through FCD, they may fall into that childless adult population who's not working, and therefore your healthcare is gone. And then what happens on that other side of things? The proposed budget includes 16 million for the Office of Opioid Abatement. Is this a full accounting of the fund that DBH will have the authority for to spend in FY '26?
Yes, it is.
Yes, it is.
Are there any remaining funds that are not reflected?
At this time, there isn't. And
Okay.
funds come in throughout the fiscal year, so we
Yeah,
have to
right.
adjust the budget accordingly once the fiscal year starts.
Okay. I understand that a total of 8 fire and emergency management services positions, including 2 community outreach specialists and 2 advanced practice providers funded through the opioid abatement fund, are now included in the opioid abatement line through the MOU.
Mhm.
Am I getting that all?
No.
Okay.
Yeah.
This is a continuation of the FEMS initiative from before, correct?
Well, actually, this is a new initiative. This allows a fire and emergency medical services to do induction in the field.
Yes,
Yeah.
they're doing it now. That's what I'm saying.
They're doing
This is
it now.
This is a
Yes.
continuation.
Uh-huh.
We had the hearing with Chief Donnelly last week,
Okay.
so I just want to make sure we're all on the same page here. The chief said they didn't need any additional people at this time because they're still like working out the kinks, and also they haven't had the same type of uptake. It's been slow, right, in terms of, but they're continuing to sort of work on that. So we'll continue to monitor on that front. I'm gonna stop for a minute because we've been joined by Councilmember Brianna Doe from Ward 1. Councilmember Brianna Doe, we're doing 10-minute rounds.
Thank you.
Yeah.
Thank you, Madam Chair. I know that we are facing difficult budget decisions, but I refuse to believe that chopping critical programs that we know are making a difference in our communities is the only way to get through the challenges that we're facing. So I want to thank you, Madam Chair, and also our colleague, Councilmember Parker, for discussing some of these critical programs today, including crisis response teams, school-based behavioral health, and the Park Road Stabilization Center. Good to see you, Director. And I'm grateful for the work that we are doing together on the Park Road Stabilization Center. I did not see any funding for the substance use disorder targeted outreach grants, which have seen great results in areas that have faced substance use disorder challenges for years. Within 6 months of starting up their program, HIPS had achieved a 51% decrease in non-fatal overdoses in the 500 block of T Street Northwest. And all of this progress will be lost without this funding. How does DBH plan to continue this work without the grant program?
As you, Madam Chair and Madam Councilwoman, one of the things that I'm sure that you recognize is that that particular grant was one-time funding that was put into our budget, and we have not had the resources to replace that. However, we do have a number of outreach grant activities that are going on within Ward 1 that will continue, and those are services that are being provided through the SOAR grant, through the opioid abatement grant, and also through our local funds. And I can certainly give you a full accounting of that.
Are those DBH programs, or are those contracted?
They are DBH programs that are being implemented by contractors.
Okay, do you know which contractors?
Yes. Okay. In the opioid contract, for example, we have programs that are being operated by HIPS, by Family Medical Services, and I do believe we have one from District Bridges in Ward 1. Mhm.
So is it possible that the grant that I'm talking about is funded then?
I don't think the one-time grant is not funded, but I can give you a full.
Okay,
a
I
full
thought that
accounting.
HIPS grant was the one that we had funded at one time, but then I thought last year the mayor had put the money in herself. Maybe it was one time.
Yeah, but I'll follow up and make sure
Okay.
I give you the exact amount.
Okay, HIPS has been doing, and I don't know if you know this, so it's a good idea. It's a good opportunity to update you, but HIPS has been doing such an incredible job at 7th and T that they were just given free office space by a property owner right there on 7th Street to have a center that they can bring people to. And they've stood up a safe passage program for the school and the daycares so that when families and children are arriving, they've essentially cleared the area and asked those they work with to not, be there around the children, and have won that trust and support. And what we saw otherwise on that corner for so many years was just such a need for services without that daily presence, was not being addressed. And I was just at Howard Hospital last week, and Dr. Mitchell was saying, everyone has been saying they'd like the team to be able to work up closer to the hospital where the bus stop is and really be out. I know they've probably talked to you about the vans coming around, but it's just not the same thing. It's not the same thing as the same faces. So yes, I'd like to know what those are, as well as the district bridges one. And the other thing that I am concerned about, shifting gears, go ahead, please.
No, I was going to say that I have had conversations with Dr. Mitchell about that bus stop right across from the hospital.
Yeah.
And we actually did increase outreach through our DBH team there, as well as HIPS is going there, and I think Family Medical are also going to that area very specifically.
Yeah.
And I do have an upcoming meeting with him. I believe it's either this week or next week.
Okay.
To talk more about that.
Okay. I was under the impression that HIPS wasn't really allowed to go up there because of the boundaries set on the grant, so that they're kind of just like down at Florida Avenue going, hey guys, we got services down here. So as not to, but I assume that every once in a while they wander up there to just do good work. But it's a challenge, and the community navigators that are part of the district bridges program that I funded, they are in that corridor. And I think, the two organizations are trying to do more partnership, but without those grant funds, it's not possible. So what we're trying to do is make sure all those teams can remain whole. So we'll work with the committee on that. Just to shift gears a little bit, I'm also concerned that we continue to see $0 in funding for gambling treatment services. This is particularly concerning given that the mayor has proposed expanding gambling in the budget, including blackjack, commercial bingo, and poker. Do you anticipate that we'll see an increase in need for these services?
Right, and certainly I think that we're really poised to address that. Here again, gambling is a billable service within our Medicaid framework, which is unusual. I mean, every state doesn't have that, and so we do not have to use local dollars to support that. Services are available, and also a technical assistance and training to make sure that providers can address the needs of individuals with gambling addictions, which is a slightly different approach than other substance use disorders.
And is that still the case if the federal match is decreased? Will we still have the resources to do this work?
Well, I can't respond to that.
Have you contemplated that at all, or how the federal match decrease might impact the rest of the work?
We have worked with Medicaid in terms of looking at what the framework will be in terms of the rates. And I think that Deputy Mayor Turnage will have more information on that, along with our Medicaid director.
Okay.
Good morning, council members, if I may. Good morning.
Good
Sean Moise, Deputy Director, Adult Services at DBH. I want to amplify a little bit about what Dr. Bazran said about gambling. In addition to the services being available through our continuum of care today for gambling, for folks suffering from a gambling disorder, we did provide 15 hours of training to our network a year ago, and we are currently in discussions with a national player who works with several other states to potentially come to DC to provide awareness, raising awareness, education, and additional training to our provider network free of charge while they work with the local MCOs to integrate a virtual treatment consultation platform into their system. So consumers and residents in the district can get additional services beyond what we already offer.
Yeah, and that's really the National Center on Gambling Addiction, which is actually located in Maryland. I worked very closely with them when I was deputy secretary there, and have reached out to them, and they certainly will provide us with the support we need.
Thanks for that. I'm just sitting here contemplating the fact that we have so many challenges in this city already around addiction with things that are out of our control and, sources of addiction and drug use and all substance use. And then here our government is legalizing and expanding gambling, which we know is so addictive. And now we have to spend all these dollars to help people not become addicted to gambling when we could have just not legalized it all in the first place or moved to expand it. But I know that's beyond the scope of this hearing, Madam Chair. And I appreciate all of your testimony today and your partnership on all things, and look forward to following up on the details of the Ward 1 program so we can figure out where the gaps are.
Okay.
Thank you, Madam Chair.
Thank you. Councilmember Nadeau, hold on. I want to get a couple of clarifications on pieces. So let's start on the gambling. In FY25, there was $300,000 that was allocated for problem gambling disorder. I think Councilmember Kenya McDuffie sent that money over. What happened to it? How'd you spend it?
We did not spend it in a very targeted, specific way to address gambling disorder this year. We were looking into options and trying to find ways to
We did training.
but that was the year before. We did utilize the money from the previous year for the training I referenced, but
Okay, so this money got swept, or you spent it on something else?
it was part of our general fund, general budget
For DBH or for the city?
for DBH.
Okay. All right. I know you mentioned that gambling is a billable service through Medicaid, but one of the reasons I think that Councilmember McDuffie was allocating this funding in terms of the expansion and growth of gambling and otherwise is that, let's say I'm a middle-class person with employer-based health insurance. If I have an issue with gambling and my insurance doesn't cover it, who do I go to for help? It's always great that we have Medicaid for a lot of people. Then you got the other folks who disposable income allows for them to actually participate in gambling, perhaps at a higher rate. What options do we have for them?
Again, based on training I referenced earlier of our general network, they could go to a provider and within our system who's been trained, who has special expertise in that area to receive services. If
Okay.
they're paying privately.
And then on the targeted outreach grants, in the spreadsheet that we have on contracts, it's showing $600,000 for targeted outreach. If that's not for what Councilmember Nadeau was talking about, then what are you going to spend that money on?
Okay, I have that. For targeted outreach, okay. I think that it's 200,000 for $200,000. Some of the money is in opioid grants, by the way, in the opioid abatement thing. We have 200,000 in targeted outreach for family medical. We have 200,000 for HIPS. That is a part of targeted outreach.
But who's
Opioid abatement. It's from it's in opioid abatement. I'm sorry.
Right. This is what we're trying to figure out. Is the money there for the targeted outreach grants that we have been funding in wards 1, 5, 6, 7, and 8? Or is it being cut? Because we're showing 600,000. You're giving me the names of the companies for whom currently have these contracts. If it's there, we're good. I think it's a little less than what we've had before, so we can sort of work through that. But we're just trying to understand if we're talking about the same thing, or do you have some other contractors that you plan to use for targeted outreach that we don't know of?
No, and I'll get back to you with the specifics. Okay.
Okay. All right, we'll follow up with you guys. That's
Yes, please
that's
follow up.
super important for us to kind of know what happened there. Now, Councilmember Nadeau spoke a little bit about some of the outcomes information that we were able to get from the T Street location, which has been incredibly successful. During the opioid hearing, we heard we had some challenges for one of the Ward 5 locations on North Capitol Street because the grant came a little bit late. My question is, how are we evaluating success? HIPS has a mission-driven need to track their data because they are trying to do something much bigger in the district, which is great. As an organization, they're doing that. What is the Department of Behavioral Health requesting from the other grantees with this money in terms of outcomes data?
I can share that. One of the things we want to know is how many people are encountered by the outreach worker. We want to know how many referrals and linkages occur, because the goal is to get people to services and supports. And sometimes, as you know, it takes time to do that. And we also want to ensure that they are present in the area that they're doing the outreach in. And I think those are important things. And the referral and linkages is not only to SUD services, but also to housing assistance, to mental health services, to primary care services, which is really key.
Mhm.
A lot of people have those as issues. And then also whether or not the teams are going to community events so that they become familiar with what's happening in the community, and the community becomes familiar with them.
Okay. When you all receive those reports, are you doing any field check-ins? And I'm asking this because some sites, when we talk to the ANCs or the communities, some sites, the contractors are more visible than others.
Mhm. We do have staff at the Department of Behavioral Health who are out there in the field, who are at the supervisory level, who are moving around and seeing what's actually happening on the ground. So it's not just paper and a paper report, but physically somebody is out there really looking.
Okay. All right. I want to, did that, Councilmember Nadeau add some clarity? So we'll figure out, yeah, I think if it's only 600,000 there, then that's enough for 3 sites. So then the question is which 3? Because I think we are at 6.
I have that.
So we kind of have to figure that out. And then you, just to clarify, Dr. Bazaran, this is opioid abatement funds?
Yes, there's some opioid abatement funds. There's money in them.
Okay, so we'll
Mhm.
figure out and then.
But I will get back to you with the specifics.
Okay, and we'll go from there. Okay, thank you. I want to go back to opioid abatement in the 4 minutes that I have here. So stakeholders have raised some concerns that the opioid abatement fund's current grant process is not strategic enough to address the highest priorities or evidence-based interventions. What steps is DBH taking in FY26 to improve the grant alignment and oversight and accountability for these funds?
Well, I think that we also we attend and are listening to what happens in terms of the Opioid Abatement Council, and also to what degree we are addressing the 14 areas of focus that were set up, where there are gaps in terms of the services and supports that are needed to support our Live Long DC plan, and using those data to establish priorities.
Okay. Last week was the hearing for the Office of the Chief Medical Examiner.
Mhm.
And I asked Dr. Diaz around the funding for the illicit drug surveillance program, the full
The 400,000. Yeah.
toxicology, to ask whether or not they got local funding or federal funding to backfill, and they did not. Would you support funding them for an additional year
Yes,
through
I
the
would.
abatement fund? Okay. we heard testimony at the hearing last week around a lower cost generic versions of naloxone becoming available, or I guess about to hit the market soon. That could perhaps offer some significant savings to us. Is DBH exploring these lower cost options? It's not on the market yet, so hard to say, but just.
We're exploring it. We do know about it. And we also want to look at efficacy and the degree to which it does the same as what we're buying.
Okay. My last two questions on in the opioid abatement portion. There are two issues or things that people have raised in terms of desires to see investments. One is establishing a behavioral health urgent care clinic, which we've talked about in the past. The other, which popped on Friday, which was a number of individuals who were testifying about establishing an Office of Men's Health. I want to give you an opportunity to speak to either or both of those.
Okay. The urgent care clinic, as you know, is really a clinic that would be similar to the urgent care clinic we have, but would have substance use also there. We've looked at that model, and the model is very interesting, and we would like to continue to explore the feasibility of that model. In terms of men's health, as I think was your opinion during the hearing. I don't know that DBH is the proper place for that.
Okay. All right. I don't have enough time to get another question off, so I'm going to turn to Councilmember Wendelfelder from Ward 7.
Thank you, Madam Chair, Director, and members of your senior leaders. Good morning to you and members of your senior leadership team. I'll jump right in. With a 24.6 million increase in special purpose revenue for the opioid abatement program and 4 new FTEs, how will DBH prioritize establishing syringe exchange and naloxone distribution sites in Ward 7 where overdose rates exceed city averages?
Well,
I'm sorry. I'll let Dr. Baswan talk about the programmatic side, but I'll start with the budget side because that's important. There wasn't a $24 million increase. That actually was a data entry error that was corrected in the budget book.
Okay, thank you for that.
Okay, in terms of looking at syringe services and the other ones, pardon me, Mr. Felder, what was the other one? Naloxone distribution.
Yes.
We have adequate funds in our state opioid response grant to support that. And we just had a couple of weeks ago a huge delivery, and those supplies were distributed. And anyone who needs them, we can meet that need. Syringe service programs are also funded through our state opioid response program, and we do have funds to continue that.
Well, thank you, Director. The proposed budget adds 1.8 million and 4 FTEs to the Access Helpline. What specific measurable improvements in response time, call handling capacity, and overall service quality does DBH expect?
I think that we do follow the federal guidelines. So, for example, we want to make sure that we answer the calls within, is it three rings? Yes. Within 3 rings. And we track that over time. To make sure that that in fact is being done. In addition to that, I think that it's important for us to note that we have chat and text functionality, which I think is really important, particularly for our transition age youth and our adolescents, because they communicate via their devices and don't necessarily want to call in. And those also are responded to very quickly within a matter of seconds.
Thank you, Director. The community response team is slated to lose 2 FTEs. In what way, if any, do you believe that this will impact high-need communities? And what performance measures will you be using to monitor the potential impact?
Actually, they will not be losing FTEs. There are FTEs that will be funded through the 988 grant.
Okay.
And SAMHSA really supports that and wanted to see that happen. So they will not be losing 2 FTEs.
With the 2.3 million reduction in school-based behavior health funds, how will DBH preserve on-site counselors in Ward 7 public schools? If grant realignment is planned, what is the timeline to secure federal or philanthropic support so that no child loses services in the middle of the year?
Well, I can start by saying that the decrease will not impact any school-based behavioral health clinician.
Okay.
There will not be any loss of school-based behavioral health clinicians because of that. Dr. Megan Sullivan can speak to some of the particulars, but that amount really is a decrease in a contract with Cognito on suicide prevention. That company went out of business, and we are bringing that in-house. And the remainder is due to a decrease in funds to the 25 highest need schools. So, Dr. Sullivan, you want to say anything else?
I would just add and reiterate that, again, those funds are not directly funding any of the clinicians in the schools.
Mhm.
And so we would continue to provide prevention, early intervention, and treatment services to the full continuum of DC public and public charter schools.
Thank you. Your proposed budget eliminates 1.2 million in local youth crisis contracts. Will federal block grants cover the shortfall, or is DBH planning to absorb those contracts?
No, that does represent a decrease in a contract, and that is our CHAMPS contract. And
Yeah,
Dr. Sullivan.
So we mentioned a little bit earlier that our plan is CHAMPS will continue to be funded at about $617,000. And so between CHAMPS, our school behavioral health clinicians, as well as our support with our education partners and with our CRT teams, we will continue to provide crisis services for children and youth in the city.
Thank you. St. Elizabeth Hospital's net budget is up only $709,000, while Cedar Hill Regional Medical Center opened in April of 2025. How is DBH coordinating transfers between SCH and Cedar Hill to ensure seamless capacity for Ward 7 and 8 residents requiring inpatient or emergency psychiatric care, given at St. Elizabeth Hospital's reduction in nursing funding?
Well, first of all, I'd like to say that we work very closely with Dr. Coleman and his staff around the opening of Cedar Hill and also the continuing functioning of Cedar Hill Hospital. As a matter of fact, we are working right now with them so that they can enter into a contract arrangement with us for individuals that are committed to, to the hospital on an FD12, and so we can work with them on that. They have a total of 16 beds that are designated for individuals with psychiatric disorders. Up to 8 of those are for individuals who are on FD12 status. As with all of the hospitals within our community, all of the hospitals have ongoing relationships with St. Elizabeth's Hospital. Our CEO can share that, and in instances in which individuals need to be transferred from one of those hospitals to St. Elizabeth, there is that coordination that happens.
Thank you. Private grant funds for data quality and compliance increased by $48,024. How will these funds be used to bolster DBH's capacity to track active service utility trends and disparities?
Yeah, the behavioral system.
Go ahead.
The grant increases for the behavioral health information system, private grants. And I'll defer to Dr. Basron to speak about exactly how those grants support the agency.
In terms of our ongoing functioning, the behavioral health support grants actually augment our existing system of care.
Okay. How is
Our
DBH?
data system of care, I'm sorry. Mhm.
How is DBH strengthening partnerships with the Department of Human Services, DC Public Schools, and community organizations to deploy behavioral health clinicians in local recreation centers, shelters, and churches in Ward 7?
Well, I think there are two parts of that question. First, we do have staff that are co-located in those environments, and they provide on-site services and supports. The other thing that you talked a little bit about, I thought I heard you say something about individuals who might be in residential facilities.
Recreation centers, churches, shelters, and Ward 7.
Right, right. And so we also have outreach staff that do have a presence there, and they do go there to work with individuals who may be coming into those facilities. The other thing I'd like to say is that we have really increased in two areas. One, we have increased our small community grants so that individuals within the community can get grant awards of up to $50,000 to provide services and supports within their community, because good ideas come from every place. The other thing that's very useful is, here again, our outreach teams really move around the community, including in Ward 7. And I can give you some information in terms of who's there. We have family medical counseling services who is there, and they do not only outreach, but they provide after-hours outreach. So there's somebody there during those after hours utilizing their mobile unit. And they have really had multiple encounters in Ward 7. Year to date, 114 people have been directly in contact with them, and they do referral and linkage for SUD services, housing, substance use, mental health, and primary care.
Thank you. Well, I want to be, that concludes my questions for this round. I'll wait for my next round.
All right. Thank you, Councilmember Felder. We're going to turn to St. Elizabeth's Hospital. Mr. Chastain can join us. All right. We're going to spend more time on St. Elizabeth's than we have in the past.
Okay.
So let's lock in. Okay. So the FY26 budget for St. Elizabeth's Hospitals shows several decreases across a variety of lines. And we want to be able to get a little bit more insight into what exactly we are cutting on these various services. Okay, so first, there is a $2.4 million decrease in clinical and medical services.
Go ahead,
So,
introduce yourself.
Mark Chastain, St. Elizabeth Hospital. Good to be with you. And so we will tighten our belt, be more efficient in our operations, and consolidate where we can. We'll do this, of course, in concert with the entire agency, not just the hospital resources. So as an agency, we will do all the things we need to do to run a balanced budget and without sacrificing the quality or volume of services we offer.
Okay, all right. That was not very fulsome. So I'm seeing 4 FTE reductions.
Yeah.
Can I
Okay.
add to that, please?
Oh, okay,
Go ahead.
some, I can you, but that is not what we need. I got
Something
this too.
specific, please.
Yeah,
Yes.
okay.
So for starters, it's a net decrease, and the net is between local dollars and federal dollars.
Okay,
On the local side, there's a decrease of 3.6 million, and on the federal side, there's an increase of 1.2 million.
okay,
On the local side, the decrease of 3.6 million is attributed to 3.4 million in personnel services. And that is realizing the vacancy savings and a few positions that were reallocated to, one was reallocated to children's services, and one was reallocated from the local fund to the Medicaid fund.
Right.
There's an FTE reduction of 2.5 FTEs. There's also an NPS reduction of 242,000, 200,000 of which is due to St. Elizabeth Hospital consultant contracts.
Okay, consultants for what?
Education. Oh, sorry.
Okay, is that technically professional development?
Oh, we have,
Go ahead.
so we have training programs at the hospital.
Okay.
Psychiatrists, psychologists, therapists, dental residents, and others. And so from time to time, we have professors come in and give lectures on specialized topics.
Okay, are they
So
able
that
to
would be
get continuing education requirements from those types of
Oh,
trainings?
yeah, they meet the accreditation requirements for
Okay.
specialty training, and it includes all of the above and other.
Okay. Okay, that was definitely more in depth. Okay, all right. I see a $1.3 million decrease in engineering and maintenance services. No changes in FTEs.
Mhm.
Yes, that decrease is due to a net of salary reductions for salary and fringe and the decrease in fixed cost. Fixed cost was reassessed and we received a lower fixed cost estimate from DGS.
Nobody else got a lower fixed cost from DGS. Everybody else's energy bills went up, water bills went up.
And that's primarily because Behavioral Health Authority, which is DBH's main site, separate and apart from St. Elizabeth's, on that side of the house, there was an increase in fixed costs because we pay for rent, occupancy, electricity, water. At St. Elizabeth's, we're not paying the occupancy costs or anything like that. And then our energy bills last year has skyrocketed. So there was a reassessment this year and we were able to realize that cost savings.
Okay. Now, there is a $8.7 million increase in hospital administrative services.
Yes, that is a net increase. So in hospital administrative services alone, there's an adjustment for salaries and fringe, and that was a decrease of 286,000. St. Elizabeth's, as the budget book shows, that we received a one-time enhancement for overtime. That $9 million was placed there.
Okay, is it not for overtime or?
It is for overtime,
It's
but
for
yes,
overtime.
it's placed in that particular program
Okay.
code at St. Elizabeth's.
All right. Now, why put it there instead of nursing services?
Nursing was likely another place of best fit, but what we'll do throughout the fiscal year is we allocate it to the programs based off of the first quarter FY26 projections.
Okay. Now, I'm asking because there's a $4.4 million decrease in nursing services, no changes in FTEs.
Right, no changes in FTEs. That was another place where we applied our vacancy savings factor throughout the agency, and that proportion of the vacancy savings was increased for St. Elizabeth.
Okay, is St. Elizabeth's on a hiring freeze?
No, it's not on a hiring freeze. Actually, I'll let Dr. Bazwan speak to it, but the priority is to fill the positions at St. Elizabeth.
St. Elizabeth is our greatest priority because we know that those are individuals with severe and persistent mental illness. And so, no, there is not anything there.
Okay. Seeing 130,000 decrease in housekeeping services, which I gotta tell you, when I hear a bunch of nurses telling me that they have to buy their own soap, I got a question, why are we decreasing housekeeping?
And that decrease is actually in salary and fringe adjustments.
Okay. All right, but Mr. Chastain, I want to give you an opportunity to respond to a number of your nurses saying they had to purchase their own supplies.
So I think, and I'm just speculating it, that they were referring to months ago, let's say 7, 8 months ago, when we were having a vendor issue, which has since been long resolved. And we have a comprehensive program to make sure that supplies are available in all patient units 24/7 when the staff need them to take care of patients. Let me be specific. So 9 or 10 months ago, we were having a problem in part, again, because vendor, but also because of a staff vacancy. We have since filled that vacancy. We have a program, a rigid program every day, 5 days a week. An individual goes to the unit and checks to see if supplies are ready and available, and they are. We also have an electronic way of each unit requesting supplies, not just only supplies, but if there's a repair needed or other kinds of housekeeping support of any kind, they can request it electronically. And then individuals go to the unit and check from our housekeeping and other departments to make sure that the staff have supplies, that things are in good working order, and that what is needed to provide excellent care is available to the staff. So we had a problem way in the past, and I am not aware, and I actually go check myself.
Okay, but
Day and night to make sure we have what we need. So I'm confident in reporting this to you that we don't have a problem with supplies at St. Elizabeth Hospital on our patient units.
okay, well, that's also not just there, it's also on just sort of regular inventory management as well. There was testimony that the diabetic readers, for instance, are outdated.
Yes, they are. And here's the good news I have to report to you. We have new glucometers,
Right.
if that's what you're referring to.
Things, that's
They
right.
are in-house. They are being programmed to make sure they interface with our electronic health record and other systems. So they're being integrated and interfaced electronically to make sure they work. And within the next 2 weeks, they will be operational, fully operational.
Okay,
Good state of the art.
2 weeks. Now, let me tell you, the way this union works, they let us.
Yeah, that, by the way, was one of the discussions we had with the staff a while ago, and we addressed it.
Okay. Prescription eyeglasses taking months to fill.
Yes,
Is that a vendor issue or something else?
it was a vendor issue at one time in the past, but we have received a plan from the ophthalmologist of what she needs in order to meet her request, and we will fix that shortly. That happened 2 weeks ago.
Okay, so that wasn't months in the past, that was 2 weeks ago.
Yeah, well, the problem has been ongoing to some extent for the past several months, but we fixed it. It's been reported, we have a plan, and we are implementing that plan.
Okay, don't go anywhere. I'm over my time. Councilmember Felder.
Thank you, Madam Chair. Picking up where we left off, in light of the 13.8 million removal of one-time local funding, what risk mitigation strategies exist to ensure that service expansions do not undermine cooperations once grants expire?
In which area are you speaking?
In your FY 2026 budget, there's a removal of $13.8 million in one-time funds
Mm-hmm.
out of local funds,
Yeah.
out of the local funding stream, pardon me.
Yes, we have several areas in terms of one-time funding. Some of it's a Medicaid match. Some of it is related to the schools, urgent care clinic, and outreach grants. And as I said earlier, one of the things that we will look at is to what degree outreach grants are being and can be supported in other areas, like in our grant funding areas, and we will move forward. Things like the urgent care clinic that we talked about before, which was also one-time funding. We have, as Dr. Tilbrook indicated earlier, we know that there are 2 federal agencies that do most of the referrals, and we have advised them that those services can be offered at 35 K Street. We talked earlier also about the one-time funding and the decreases related to schools and Medicaid match.
So it seems like, Director, with this reduction or removal of the 13.8 million in one-time funds, there will not be a disruption, or the services that were once provided, you will continue to provide them, and it will not undermine your cooperations?
I don't think it will undermine
Okay.
cooperation. No.
Okay. Local funds dropped from 296.7 million in FY 2025 to 278 million in FY 2026. How will DBH prioritize which programs absorb the largest share of that 18.6 million reduction, as well as what critical guided decisions are implemented to preserve certain line items across this section?
Well, I can tell you that during budget formulation, we really looked at how we would make reductions in terms of a series of core principles. And the first one was how could we maintain and improve quality of care, of clinical care. And so that was one of the factors. The other thing we looked at is we focused on mandated and core services that were designed to really help people improve their functioning level and recover from behavioral health. The third thing we did is we looked at where we could achieve efficiencies. And so in some instances, it meant bringing things in-house. In other instances, it meant better coordinating the services that were available around a particular service delivery model, and also how we could maximize federal grants and contracts without supplantation. And so those were some of the things that we looked at very carefully. But our top priority was on increasing and maintaining quality of care.
Thank you. I see that in your budget, Medicaid revenue decreases by 4.2 million to just roughly over 4 million with a 2 FTE decline. Which clinical or billing functions are impacted by this cut? And does DBH anticipate any change in provider reimbursement rates or shift in eligibility criteria that accounts for the reduced Medicaid draw?
Well, at this point, we do not anticipate changes in the provider rate, but we will follow the Department of Healthcare Finance's lead because they really are responsible for the Medicaid agency. However, what we know in terms of the services that we have at this point, there will not be, cost of living increases or anything like that.
Given that Ward 7 has historically underserved sourced communities, how does DBH ensure that per capita behavioral health dollars do not shrink disproportionately compared to wards 1 through 6?
Well, I don't think that well, there are two things. One, our service system is designed to address the needs of all citizens and give them the services and supports they need. So we don't have our services disaggregated by ward. Ward 1 gets this and Ward 2 gets something else. However, the other thing that we are doing, particularly through our Live Long DC plan, is we are having ward level, community level meetings and looking at what are the needs of that community that may be specific to that community and how can we best address those needs.
Since government subsidies and grants shrunk by 17.1 million overall, can DBH provide a department-wide table showing which subgrantees will see funding cuts and by what percentage?
I think that in some instances, some of the grants that are listed there and our chief financial officer can share ended. The grant ended. And so there's no more funds coming through that area. And then there are some others. Go ahead.
Thank you, Dr. Bazran. As Dr. Bazran mentioned, some grants did end. And I'd like to add that in the government subsidies and grants category, what's accounted for there is also one-time funding for the Medicaid match. So it's accounted for in that category, which is a reduction in the budget book. But when we consider what the impact is, it's impacting a few vendors. But as Dr. Bazran mentioned, we can share that file with you to let you know what subgrantees have been impacted.
And could you speak to, if any, How will DBH support those agencies in applying for alternative funds or philanthropic grants to backfill local shortfalls?
One of the things that we did last year, and we will continue to do this year, particularly around the opioid abatement fund, is we actually held a series of community meetings. And those meetings were really designed to help residents know how to apply for different funding sources. How do you put together your proposal? How do you put together a budget and so forth? And we will continue that model in looking at how additional funding can be achieved. What we have not done is really provided any kind of training in terms of the philanthropic community. However, I used to run one of those, and so and provide that training, and so that is something that we really can take under advisement. So thank you for that.
Given cuts to DBH lines that overlap with DHS, how will DBH coordinate MOUs to prevent duplication or service deserts?
We actually meet with DHS on a routine basis. We're actually in the same building. They're
Okay.
just a couple floors above
Mhm.
us, and particularly around homeless services and housing support services. We work very closely with them. We actually, through our HMIS system, we actually cross-match individuals who are in our system and who are also in their system, and jointly look at how we can best provide the services and supports for those individuals.
Got you. Just two more questions, and I'll make them quick. Just a follow-up to my previous question. What formal risk mitigation strategies are in place if with partner agencies in the event that they lack capacity to absorb increased referrals?
In terms of risk mitigation, in terms of somebody who needs
Yeah, so like
behavioral
say
health
for
services?
example, the work that you guys do, and that may overlap with DHS. There may need a housing support, so there may need to be a referral, or with DCPS, school-based behavioral health, through to you guys might work with them, and they may have seen a decrease in funding. How are you guys working with them to absorb that?
Well, I can give you an example of one of the things that we're looking at. If you take Wayne Place, for example,
Right.
CFSA and DYRS are our partners there. And so we actually are providing funding to support young people through the Transition to Independence program. And it will address specifically the needs of individuals who may have some juvenile justice involvement, as well as individuals who are aging out of CFSA and individuals with substance use and mental health disorders. And so that is an example of a collaboration. In addition to that, we also have co-located 211 in our building in some vacant space. And so that really took some pressure off of CFSA to try to find another place.
Gotcha. And my final question, Madam Chair. Okay. Spending in your FY 2026 budget, spending jumps from 2.6 million to 4.4 million, and FTEs from 27 to 31. How many additional calls per month does DBH project to handle with those 4 new positions? And will this reduction average hold time from the current 30 seconds to fewer than 15 seconds?
Well, first of all, I think the additional staff are really staff for the 988 line.
Okay.
And you may remember, we do have 2 new services there. We also now have geo routing services, so we're getting more people who are within our district boundaries that we can provide services and supports to. And so I think that we want to maintain the national standard in
Okay.
terms of our answer rate, and we also collect data on that and make the appropriate mid-course corrections. Dr. Boozer earlier talked about the fact that we are staffed sufficiently to do that, and the additional staff are cross-trained to cover the full range of services.
Thank you, Madam Chair.
Thank you, Councilmember. I believe we need a 5-minute break. So why don't we take that now and then we'll come back to St. Elizabeth. Thank you. Oh. Okay, and we're back. All right, so we just finished with Councilmember Felder's questions. I'm gonna go back to St. Elizabeth's. We were walking through some of the increases and decreases overall to get just a little bit more clarity. Area of increase, it was about only 68,000, but it was for security and safety services. What's that for specifically?
That was an increase due to salaries and fringe
Okay.
for adjustments.
All right, let's talk about security just a little bit further. The current security staffing at the hospital, is it contract or in-house?
It's a combination. They're permanent full-time employees, approximately 23,
Okay,
and then they're contract employees, 22, 23. It's about 50-50.
okay,
Contract employees are security officers. The regular full-time employees are special police officers.
okay.
One can arrest, for example, one cannot. The security officer cannot. Their function is primarily observe and report. An incident. for
Observe
example,
and report
observe-
and intervene or no?
No, they would not restrain or arrest, place cuffs on an individual, for example. But the special police officer could and would.
Okay, all right. So 23 permanent folks, special police, can observe, report, and intervene. The 22 contract folks are observe and report.
Yes.
Okay. How many are assigned on each shift?
Well, so we staff, including security officers, to acuity. If there's a particularly disruptive patient, for example, in our highest acuity unit, we'd have one special police officer assigned to that individual 24/7 because of the acuity, the potential of them to do harm to self or to others, along with clinical staff, a behavioral health technician, an RN, and a security officer.
Okay, you're talking about levels of acuity. Let's go back. So in Dr. Bazaron's testimony, she talked about how the hospital is now back at pre-pandemic levels in terms of population. Think about average of 270. Is that accurate? Okay. But
And
the population has changed.
yes.
What percentage is forensic versus not?
So with regard to admissions, forensic admissions directed to us by the court are over 90%.
Okay. Have you made any corresponding changes in your security plan, given that your patient population has changed?
Yes,
Say more.
yes. For example, there are more patients daily who are on what's called one-to-one observation 24/7. So that's when a person, based on a risk assessment, a clinical risk assessment, for them being disruptive, assaultive behavior, for example, doing harm to other persons, need someone observing them, doing nothing but observing them 24 hours a day. So that has increased to correspond with the increase in forensic admissions.
Okay, so who is the person who would do the observations for that one-to-one assignment?
That would typically be either a behavioral health technician or a security officer, depending on how high the risk evaluation determines the need to be.
Okay, so since the change in population, which I'm gonna just go from what was pre-pandemic to now, so in the last 5 years, have you increased the staffing in terms of the number of behavioral techs that you all have hired?
So we have filled all of our, we're filling a much higher percent of our vacant positions. We're constantly recruiting. There are probably 10 vacancies.
Out of how
at
many?
the moment.
Out of how many?
There are a total of about 430 nursing staff. Approximately half of them are RNs, and the lion's share of the remaining staff are BHTs.
Okay, that's what I'm asking for.
About-
Of the behavioral techs, how many do you have and how many are vacant?
Approximately 180 60 behavioral health techs. I can give you those exact numbers. I'm happy to provide them to you.
Okay. And you're saying only about 10 are vacant?
10 to 15, yes,
Okay.
at any given moment. It's the normal turnover rate, if you will.
Okay. How many behavioral health techs are assigned to a unit per shift?
So it depends again on the acuity. It can be as high as 5 or 6, along with RNs, 2 or 3. And that can include additional support from a security officer and additional assignments of one-to-ones to supplement based on the patient's needs and propensity to do harm to self or others, a one-to-one if it's a particularly disruptive or a high acuity unit.
Okay, so let's
Like-
take, for example, we had 2 people who testified Friday from a particular unit that they said should be 7, but it is 2 because there is a patient for whom the violence level is so high that other folks had to be moved out of the unit. The other person just didn't want to move. What is the staffing for that one unit?
There are no units with 2 staff.
No, 2 people.
2
Patients.
inpatients,
Yes.
yeah. No less than 4, plus supplemental security and additional one-to-one.
Did you?
So a particularly disruptive individual has the potential to harm self or others, has a dedicated staff that does nothing but care for that individual. They observe, they intervene if they become disruptive or agitated or need some personalized care, which happens. And so we staff to the acuity to maintain safety and to meet the individual patient's needs.
Okay, did you watch the hearing on Friday?
I had staff that watched it, and I did not personally,
Okay.
but I did have staff that watched it and reported in great detail to me.
So are you saying that the description of 2 of your nurses, that there is a unit that should have 7, has 2, and it is not properly staffed with a special police officer is inaccurate?
I don't know exactly what you're referring to. There is no, we have a unit, and I want to be careful because in the interest of patient privacy, how I talk about these
The name
matters.
of a person, right? I just got a number of people
Yes, yes.
and a description of activity. That's it.
Yes. And so we do have units where there are patients who need high patient to staff ratios, and we provide it. So at our highest levels, we have 3-to-1, 3 staff, which would include a security officer, an RN, and a BHT, whose exclusive responsibility is to care for a very unstable, clinically unstable individual.
Okay.
On units where we have much lower census, let's say, for an example, one where we have 2 individuals, we have no less than 4 individuals plus a supplemental staff security officer who's committed to that patient.
Okay. Do you believe that the current staffing levels and security protocols are sufficient to protect both patients and staff? Even though you've testified, and we all know the patient population has changed. When I go to Georgetown, MedStar, GW, Washington Hospital Center, their protocols for patients who are there under forensic reasons look very different than the regular hospital protocol. In fact, for all of them, they have an MPD or Department of Corrections officer with them the entire time. Even sometimes I got correctional officers who try to be in a room when a woman's giving birth, and we gotta just move them out, right? So when I am hearing you talk about the protocols, and I respect that it is an inpatient psychiatric facility, but we looked back in the budget, I don't see any corresponding changes in response to the population has changed. And so, and I know you didn't watch it yourself, but I will tell you, I have a lot of hearings. I rarely have 20 to 25 nurses from an institution. They may not all have testified, but they were all here, who have taken time off work to come do it. And so it calls for me to have to question what's happening.
And so I understand that. And here's my response. The hospital is extremely busy and we're busting at the seams. And we are busting through our pre-pandemic census and activity. We have a wait list, to be more specific, between 10 and 15 every day now. That includes forensic wait lists as well as a civil wait list. And so the demand to come to the hospital and be treated is at an all-time high, okay, and growing. That in many ways is a good thing. It's a statement of confidence in the quality of care and treatment that we're providing. But it also raises new challenges and poses new resource requirements. And we will meet those. We are always adjusting to new challenges and new demands. Do we need to do more to address safety concerns? Yes. And we have a number of proposals and discussions underway at the agency head level to address those new demands and new requirements, and we will.
Here's the thing, I don't see it in the budget. And if you're saying you're gonna use what you already have, then that means you're robbing Peter to pay Paul. That means you're cutting from something else that's already at your hospital to pay for security, which means that the needs of somebody is not gonna be met totally. And so that's where I'm struggling with this because, you know, one nurse testified that in her unit, out of the 20 staff members, 7 have sustained injuries, including some requiring intensive medical treatment and ongoing therapy. I only see a $68,000 increase in the hospital security line. I'm seeing nothing in terms of increasing staffing. So help me understand how we're matching the severity of what's going on or the scale of what's going on with this budget. And I can appreciate that you have a plan.
Yes.
But I don't see it. And I have nurses who are questioning, right?
Yeah. So there are things we have to do and will do at every level in the organization. The psychiatrists have to do some different things. The psychologists have to do some different things. The clinical team, including the nurses, the security officers, BHTs. And yes, we need to add additional resources if the current demand persists, and I have all reasons to believe that it will. And Dr. Bergeron is committed, the agency leadership is committed to respond if and when additional resources are required.
Okay,
We need to recruit faster.
I'm gonna read you something.
Okay.
A patient's brutal attack on a nurse at a DC government psychiatric hospital has renewed calls for increased security at the facility, with staff and union representatives saying hospital managers have been slow to respond to requests for safer working conditions. The January 13th incident at St. Elizabeth's Hospital in Southeast Washington, disclosed at a routine oversight hearing of the DC Council's Health Committee, left a 71-year-old nurse with badly beaten face and 2 fractured ribs after a male patient escaped from his restraints and clubbed her repeatedly with a telephone. The nurse said that the attack would not have been possible if the hospital officials had installed security barriers at nursing stations, a measure the staff has been urging for years. Quote, "It could have been prevented," she said. Mark Chastain, the hospital's executive, said in an interview that plans to fortify the nurse stations were underway before the attack occurred and that the improvements should have been completed within 120 days. Quote, "We're very sorry it happened," he said of the assault, end quote. This was February of 2019.
Yes. Since then, we delivered on the comment I made. 6 nursing units, barriers to prevent that sort of incident have been installed on 6 different units.
How many units do you have total?
12.
What about the other 6?
The others, the patients that typically are housed and admitted to those units are not as aggressive and assaultive.
In 2019?
Yes. So we have 12 units. Some units are not housed by patients, and patients who are on those units are not as assaultive or aggressive. Some, in fact, are geriatric, as an example. Different demographics, different disease processes in place, less assaultive. The acuity level is not as high and does not warrant a barrier. It's the configuration we're talking about is comparable to what you see if you go into a bank, for example. With this,
No, I've seen them at the Psychiatric Institute of Washington. Dr. Bazaran and I've done a tour there. So
but you've been to St. Elizabeth as well.
Yes,
Or did you?
I did.
She did.
Yeah.
I have.
Yeah.
Also with Dr. Bazaran. And so I've seen it in some cases, but what I am saying here is that if you're now at over 90% of your population being forensic,
Yeah.
that's great that you have that for 6 units, but I've got nurses who are saying that they feel unsafe
Yes.
in terms of the build out of one way in, one way out.
Yes.
There's no money in the capital budget to do the other 6.
So here's the reason. We have continuous and ongoing discussions with staff about this very issue. And we do an evaluation based on all of that input. We look at the number of assaults, unit by unit. It is not our desire. It is not, a number of the nursing units leadership don't want the barrier. It creates a barrier between them and communicating with the patients. The staff behind the desk want to have an open, uninhibited way of communicating with the staff, to keep communications open and lively, if you will. So a number of the units, the staff don't want it there. We don't want to put barriers on every unit in the hospital because it impedes relationships and communication.
Okay.
And so we have put it on the units of the highest acuity, where the predisposition of patients admitted there and propensity because of their disease is to attack and assault staff, perhaps, and other patients.
Okay,
And so we've responded to that commitment I made years ago before the
but the
pandemic.
question that I have is on the security side, right? So if I don't have the barrier, fine. Various acuity levels, various levels of aggression, et cetera.
Yes.
But then the union president testified that there is generally 7 security per shift.
Yes,
You have 12 units.
yes,
7 security per shift doesn't necessarily mean that they are in the unit. 7 security per shift means that they're on the hospital grounds. Is that accurate?
it's inside and outside. There is one officer, for
Yes,
example,
I'm-
patrolling 24/7.
Okay,
Okay,
so if something goes down on, say, unit 10,
yes,
they have to wait until a security officer who could be outside or could be tending to another unit is able to make it to unit 10. Is that correct?
yes. But I'm suggesting that your premise, let me clarify what the premise I'm coming from. Because a security officer is not on a unit, doesn't mean the staff are unsafe or that the patients are unsafe or that there's violence going on. Not at all. Our staff are trained to de-escalate, to engage with patients, to address any issue that may arise. And if it's beyond their ability to address, they call a code. A code is a call for help from other units and, yes, security officers to evaluate and get the situation under control if it's out of control. But the absence of a security officer on a unit does not mean that it is unsafe on that unit, not at all.
No, but I'm just saying in terms of, and I know it's different, right? But if I look at some of my private hospitals, 7 security per staff, they've got double that per shift, right? So I feel like you're below because you're not even matching where the private hospitals are from a security perspective right now. And I know you said that our nurses are trained. As a reminder, you're cutting the education and training line.
Yes.
So, why would they ask for an increase in terms of being able, that was one of the requests that they had. It was shields on the nurse units, more collaboration with psychiatry, cut the education or restore the funding for education and training on a variety of things, and then updating some of the outdated technology.
And we're going to do pretty much all of those things in the coming months and years.
With
Those
the
are included in our plans.
with the current budget.
We'll prioritize as needed. The director has stated that St. Elizabeth is our top priority,
It is.
and she will respond accordingly.
Okay.
And we will address the very list of things that you just described.
Mr. Chastain might also mention that in terms of staffing, he probably has the lowest vacancy rate in a while, correct?
Yes.
So he's really stepped up, the recruitment.
All right, let's talk about some of the vacancies.
Mhm.
Your psychologists are wanting to revolt, sir.
We have a serious crisis in the recruitment of psychologists. Our compensation is not competitive, and they're in negotiation as we speak.
Okay.
We are hopeful that
The psychologist's current CBA expired September of 2025. Are y'all at the table?
yes, negotiations are underway as we
Right,
speak.
right now.
Okay. Is there any enhancements in the proposed FY26 budget, not necessarily for St. Elizabeth's, but perhaps in the workforce investment line, that can be used to bring the psychologist salaries to a competitive level? So the workforce investment is a citywide pot where we park money for future CBAs. Are you on the list in the realm of like, we're about to work on this one and we think that we're gonna get there?
So I can say the process for that is the CBA has to be agreed upon to and signed, but that process is comprised of the mayor working with the CFO to figure out if funds are there. So if the CBA is signed, then DBH would be able to receive an allocation from the Workforce Investment Fund to fund those agreements.
Okay. All right, so we're just starting conversations. We have a vacancy problem there currently. I have a BSA subtitle, which is not on yours, but it's a BSA subtitle that essentially says that any CBA after May 15th of this year cannot have any retro pay. And so I'm a wish y'all best of luck at the table, because I feel like we have a crisis here of you got a CBA expiring. There's no way that you're going to have a completed CBA in time. So there's going to be a gap period. And then now the mayor wants to say nobody gets retro pay beyond that. So, okay. How are we meeting the court mandated timelines for competency restoration and treatment? Are we at a legal risk here?
We're doing what we have to do. In some instances, we are authorizing overtime. In other instances, we're all looking at creative ways of utilizing the staff that are on board, our very committed, dedicated staff that are on board to do more. Yes, we're asking them, and they are responding heroically to make sure we don't get in trouble.
Okay.
As best we can, but it's not sustainable over the long haul. As I said, we're in negotiations now, and we remain hopeful that we can make a breakthrough.
Okay. Let's talk a little bit about overtime. So as we talked about, the proposed FY26 budget line includes $9 million enhancement to support staff and overtime. The FY25 supplemental, which we haven't talked about yet, included another 3.4 million specifically for overtime pay for nursing. So that tells me that we've got some sort of issue and a pressure. If you need 3.4 million in overtime this year, and then a 9 million in overtime next year. So what's driving the overtime costs? Because I asked some other agencies who are also utilizing overtime, and they have a litany of variety of issues which lead to it, not just including vacancies. So what's your issue list?
Our list is as long as those other hospitals. So just a little background. So for 35 years, I ran med-surg hospitals. And so I have a good understanding, excellent understanding of the pressures, the workforce shortage issues, in all hospitals, including specialty hospitals like St. Elizabeth Hospital. And so before the pandemic, let me just step back a moment. Before the pandemic, there was a shortage. The pandemic hit, and then many healthcare workers didn't want to work in the environment where the threat of them contracting a disease that could affect them and their families is simply bailed out. Others just didn't want to continue in nursing. And so we went through that crisis. During the pandemic, compensation went through the roof. You read stories about $300 an hour for traveling nurses who worked on the weekends. And extraordinary things happened during the pandemic, and it was necessary. Things have settled down. We're beginning to see responsiveness to our vacancies that we did not have during the pandemic. So applicants are now applying to St. Elizabeth. The prevalence of COVID has subsided. So our vacancies are declining, and filling vacancies is the #1 way we can reduce overtime. Okay. So that is happening, that's occurring. Overtime is coming down.
Okay, so how many vacancies do you have in nursing right now?
So RN vacancies, I have approximately 16 or 17.
Okay, but it's not just vacancies. I'm sure you have somebody out. Go ahead, Abe.
Can I add just a little bit? I do agree with what Mr. Chastain mentioned. Additionally, I look at overtime from two perspectives. One, the actual cost, to the actual hours. So I speak to the cost. The cost increased because of the CBAs. So we had to partially adjust the budget for the increase in cost, even if we're the same amount of hours.
Got it.
The other factor, the hours, is what Mr. Chastain was explaining. And I think that one of the ways those hours will be reduced is there's a current proposal on the table to revise the allowable FMLA. That was contributing.
That was going to be my next question in terms of the litany of things. If FMLA is a challenge for St. Elizabeth's in the same way that it has been for the other hospitals, but also how many of your folks are, well, no, FMLA, that about it, that covers it. Family leave. What percentage of your folks are out?
A substantial number of our staff across all disciplines utilize the FMLA benefits, sick leave, FMLA benefits, and other benefits.
No, I'm talking medical, right?
How many are out? So we've done a lot of good work on returning everyone from a non-productive work status back to a productive work status. And certainly the change in benefits the mayor has directed will certainly help our situation in terms of non-productive work status and being out.
Okay. One of the things that was also discussed on Friday was around inventory management. We talked about this very briefly, but because we only see you. I'm imagining you have a COO of some sort.
Yep.
All right. And some other folks in terms of the operations piece. Are you confident in your inventory management system that you currently have in place?
Yes, very confident. Doing an excellent job. How do I know? Why would I say it that way? We have meetings, all hands meetings with our staff. I had one on the 28th of May at the noontime and at midnight. And we asked them, and they told us, the patient unit staff, and they, the general employee body, that things are much better. We had a problem months ago, 6 or 7 months ago. We've done specific things to improve it, and I'm confident that it is improved. I go to the units myself and ask. I personally go at night, during the day, and ask the question because being out of supplies is unacceptable.
Do you
That's
have
on me.
when you have someone on your I guess you bring together your leadership team, et cetera, are you bringing in the chief of nursing?
Yes.
To, I guess, report out from the nurses of like, hey, we're seeing this X, Y, or Z?
Yes, I do.
Yeah, also it's a computerized inventory system that really does allow the CEO to know where more supplies are needed and to make sure those get distributed appropriately.
Okay. Mr. Chastain, if we added additional funding to the budget, are you going to spend it or
Absolutely.
do what gambling did? and
No,
take it for
absolutely.
someone else?
I'm not making light of it. It's absolutely, we are adjusting. We are busy. The demand is extremely high to be admitted to the hospital. Our wait list is high. And we will meet that challenge. We gladly and enthusiastically do more if we have resources.
Okay. I know that in these hearings, it's always difficult for people to speak honestly in terms of, want to say the party line, not get in trouble, et cetera. But like, I'm concerned. Is on the one hand, I've got folks who are there every day who are telling me there's a problem, right? I've got lawyers for people who are representing some of your patients who are saying there's a problem. And then you're sitting here and you're telling me, nope, that was 7 months ago. We're good. So I'm like,
I'm saying,
I feel like for your hospital in particular,
Yeah.
right? Forget the rest of the government in general. You need to advocate for what you need, irregardless of the politics, because the consequences are too great if we fail in terms of what could happen. But also, I'm not interested in another court decree for the hospital, especially with this federal government, right? So like, we gotta just make sure that we're crossing our I's and dotting our T's. And when I look and see that like there hasn't really been significant shifts, even though the population has changed at the hospital, let's talk more about that offline of what is actually needed, because while you said a number of times we'll make it work, that doesn't tell me need, that tells me you'll make it work. Okay. All right. I've got like 2 more sections and so let's just push through so we can wrap up. I want to talk a little bit about housing. So the proposed FY26 budget allocates $27.2 million to housing, residential support, and community continuity of services. It's about a $2.7 million increase from this current year. I understand that the reduction can be attributed mostly to unused vouchers.
Correct.
Yes, 1.2 million of that is for, there was a contract titled Pathways to Housing. That contract was put there and it was, that was reduced. That was one-time funding that was for court urgent care. And then the 1.5 million was due to the vouchers.
Right. And
Okay.
if I might explain what happens in terms of vouchers.
Yep.
And what happens is essentially, as you know, and you've heard me say this before, the amount of our vouchers is well below FMR. And they're
One below FMR. Did you say FMR or?
FMR. Yeah, fair market
Okay,
rate,
thank you.
okay? And so our vouchers are below fair market rate. And so often individuals who have those vouchers may not be able to find an apartment that they like or that they want to move into. And so it takes them longer to find an apartment when there's a vacancy and they have the opportunity to lease up. And so during that period of time, we obviously, excuse me, are not paying
Mhm.
the monthly fees and so forth. And what we have calculated is what that vacancy rate looks like.
Okay. So you're not giving them up in
No,
total?
we're not decreasing the number of vouchers at all.
Okay. Do you want to be in the housing business?
We started this housing process with, I think that this was back in what, 2018, maybe? We had some bond funds, and certainly one of the things we know is that individuals with severe and persistent mental illness do require housing. And so we created a housing product. And it included housing vouchers, CRFs of different levels, so that we can make sure that people who are in need have a supportive environment. And so that is the way we have run our operation.
I appreciate your answer, but that was not the answer to my question. My question was, do you want to be in the housing business?
Here again, I want to make sure that the needs of our clients are served.
Okay. Is I'm asking in sort of that way because I feel like someone being served in a community residential facility is different than someone who you described with severe and persistent mental illness being served with a housing voucher out in community where they have the option to engage or not engage in
That's correct.
services. If Councilmember Fruman were here, he would speak on this. I think he has his own hearing today, but there this overlap that has sort of been occurring. And so how do we make a decision between someone using a voucher versus someone going into a CRF?
Well, I think that first of all, it depends, that's a level of care determination. So there's some individuals who need a certain level of supports that they will not get if they are living independently. They
Yeah.
don't have the skills to do that. And so that's why we have various levels within our CRF, our community residential facilities product, and we also have the vouchers. And I might say that individuals who are within the public behavioral health care system can apply for housing at DHS or through the housing authority. And we will help them, our core service agencies, to get those applications in place so that they can get the housing they need. And the doctor.
Well, so let me
Luis is
ask
over
this,
that.
like, I respect that someone has a choice,
Mhm.
but who on your team would intervene for someone who is applying for just a voucher when the clinical look at their notes suggests that is not a suitable placement?
You want to talk about
Or are we
personal
just-
housing?
I feel like we have a tension between sometimes we just want to get people housed, like we want them out of the shelter, out of an encampment, off the street. And so we're putting folks who perhaps are not in the right placement just because the voucher was available and a bed in a CRF was not available.
Sure. Council member, a couple of things. To answer your last question about who makes that determination, our voucher programs and CRFs, the group homes from DBH versus DHS, other sources, require that somebody has an issue, has a behavioral health issue. Otherwise, we would refer them to DHS to get your voucher from them or DCHA. So, and then that process involves a clinical assessment and support and analysis by our community service agency, a behavioral health provider in the community, working with the individual to determine what their needs are and what level of care they need. So the first split is voucher versus CRF, a group home. So it's clinically based. It's not like we sit behind our desk and we make that determination
No.
without engaging.
So let me ask
individual.
clarifying. So that's something that's happening. I refer to you guys as DBH central office versus your core service agencies.
Yeah, all the decisions, we manage the process. The
Right.
decisions, we have clinicians obviously at DBH, but this function and service is not a clinical function. It's an administrative management function. So out in the community, somebody presents as needing housing. And based on their level of care, they might go this direction, which is a voucher-based program, versus this direction, which is a group home community residence facility. And within the CRFs, there are different levels of care depending on the person's need for support, intervention, and so forth. So, and in addition, for the people in the voucher program, we have a couple of strategies to support them, even though they're scattered throughout the city. One is our PATH grant, which is a group of, a team of about 11 people, 11 or 12 clinicians, peers, and a nurse that's the team that sometimes and often goes when encampments are being cleared and so forth, to assess people and to support them, to connect them to care and to, help them work through the process of getting housing. That team also engages people in various sites, scattered housing throughout the city through the voucher program. In addition, just in March, a few months ago, we executed a $1.7 million grant, which is being executed, managed by Community Connections, purely focused. We're calling it our Housing Support Care Management Program. And their job is, and they have a team, and they've already enrolled or identified with our help 275 people, almost 300 people they're targeting to support who've been reported as having a need in the community on the voucher side, to engage them, to assess them, to provide support, connect them.
Okay,
to
that was
care,
the
and so
intensive
forth.
care coordination grant from last year that you guys told me I couldn't cut.
Intensive care coordination is different. I'm sorry for
Lord. Y'all name these things like all the
You
same.
do it just to confuse you.
Healthy futures, healthy start, like care
Intensive-
coordination,
they're all
intense care
simple.
coordination.
Simple.
No,
No, I
you
want to
be-
differentiate. Intensive care coordination is about getting people into the hospital or out of the hospital, back in the care. It's to ensure that people who are acutely ill, either coming from out of St. Elizabeth's or a community-based hospital, get the care they need. It's to connect them. It's less about housing.
So this new thing on housing is a new and a different
is
pot of
new.
money?
New pot of money.
Okay, y'all needed to confer because somebody behind you is giving an alternative response.
Okay. It's okay. Housing. Housing coordinator. Yeah. Okay, I think we're saying the same thing.
They're saying the same thing.
Okay, so intensive care coordination, like I said, is about helping people coming out of the hospital, like St. Elizabeth's or community hospital. The housing care management support program grant is specifically to support people in the voucher program.
Yeah, it's like 1 million and some change.
Yeah, 1.7 million, and that's their function to.
That's why I was asking, is it the same as the intensive care coordination?
No,
But different, okay, we'll
no,
We'll
this
get
is,
through
I,
that.
I can tell you how this came about.
Okay.
Essentially, as we were, I meet with members of the community and particularly members of the community who manage apartment buildings
Mhm,
throughout the city. And one of the things that came out of those meetings is that we have a number of individuals who have vouchers of various types. And they really are struggling in order to live successfully within these buildings. And
Mhm.
we need to have some supports that are targeted on these individuals to help them be able to live successfully within the community in an independent living arrangement. And so we designed this program, which Community Connections is the awardee. It's a $1.7 million program, and it is to provide specific supports for those individuals who've been identified by the neighbors in their building management, saying that they need additional support.
Right. Dr. Ruiz, I'm gonna try to ask it in a different way. But again, who gets to make the final determination of whether or not a voucher is a sufficient living environment versus in a facility?
We ultimately make that decision, I'm saying. That's correct.
DBH Central.
DBH Central.
Okay,
because
that's
we
what I'm saying,
manage the
like-
program. But yeah.
You kept referring back to the CSA, so I was like, okay, so somebody in the community
You're
getting to make
considering,
this
since we're
decision.
not treating the individual, we consider their history, their needs today, which are often tied to a CSA and the services and supports they're getting today
Okay,
outside of DBH.
what
Central.
happens if somebody who has a voucher, but you all have determined either through this new grant or other incidents or things like that that come up, that, you know what, independent living, even with the best of supports, is not gonna work?
We cannot make them move or give up their lease. We have to work with them and see if they're interested in a place-based voucher, for example, where there's supports on site, or a CRF environment.
Okay,
We do
but
not have the ability to take their lease.
sure, then what happens if they go through the eviction proceedings because of safety concerns?
Yeah, in that instance, then we will provide, obviously, the support they need to make sure that they have housing.
Okay. You know the cases that we have heard, right? Some of them is like, ooh, all right.
Right.
could put the whole building in danger, right? In terms of some of the things that are happening, particularly in a
But
unit.
the federal PHS requirements are fairly specific, and so we cannot, they have their lease. We provide them with supports. We want them to be able to live within the community. But also, they do have to meet the requirements of their lease.
Okay, so the vouchers that you all have, are they all permanent supportive housing vouchers?
Yeah.
Yeah.
I mean, technically, in
We
theory.
subscribe to that model,
framework, yeah.
the same framework and model.
Yes.
Which dictates what Dr. Bazran just said.
Okay.
Housing first model.
And then in that same frame, what are the conversations that DBH is having with Department of Human Services when there is a client who didn't get the voucher from you all, who have just a regular LSRP or whatever, but there are clearly challenges that arise. How do we sort of mitigate some of that? Because what I'll tell you, what I go to a community meeting and they'll say is that DBH is not doing their job in terms of providing services. And we'll dig into a particular case and I'm like, they don't have a DBH voucher specific, they have a regular voucher XYZ, but I think for the community minds, if someone is having a mental illness, DBH is clearly involved. And so I think your reputation is sort of being besmirched because they are assuming all of these individuals you all place there and are supposed to have responsibility for, but that's not what is occurring.
Correct.
And so how do you all deal with those cases that arise with Department of Human Services?
Since COVID and during COVID, when folks were in the hotels, the PEPV, I think they were called hotels to contain and manage the virus, obviously DHS, who was managing that process, was working very, very, very closely with us to ensure that people were getting the behavioral health supports and their needs met. We've continuously, since COVID, even though that model's no longer in place, maintained that relationship, that ongoing consultation with DHS regarding their voucher holders or folks coming out of encampments to ensure when they identify somebody that they let us know and we can dispatch our specialized PATH team that provides that support and evaluation and treatment, or CRT, to manage and de-escalate a crisis, or to work with a community service agency to get that person back into care. More recently, because there have been more of these cases coming up, we're working in a much more focused, structured way with DHS. We're meeting with them every week to share data. So we're not relying so much on a call us and we'll respond, on a much more focused way to share information so they can tell us who on their roles are needing support, and we'll respond based on our number of resources and strategies that I've mentioned.
That's what I wanted to hear, was that you guys are being more proactive as opposed to the one-off,
Absolutely.
because
Yeah.
the level of
Yes.
incidents have arisen. And so I think we just needed to be a bit more strategic on.
And if I may, just one more thing. So the housing care management support team that I was talking about, they're trying to describe earlier, also involves a hotline. Where we're publicizing this to landlords and property owners and to the community, so that we don't have to hear from DHS staff or Pathways to Housing staff that supports DHS doing similar work. The property owner can call this number. It's not a clinical hotline. It's not CRT or Access Helpline, to let us know there's a problem in the building, to identify an individual, and we'll go out and engage.
Okay. Have you guys communicated that with AOBA, Apartment Buildings Office Association? They represent all the landlords.
Okay.
Because you know what happens, and Phyllis knows this, the landlords, landlords will call AOBA. AOBA will call me. I call Phyllis. That's a beautiful line of telephone, but I feel like if the landlords knew that this hotline was available to them, that could help. And also, let me just say for the record, while we love all DC residents, some of them have a little racism in their soul. And so every time that they call about a neighbor of theirs, it is not related to a serious issue. You just don't like the way the person looked today or didn't speak to you in the hallway. And those are not the appropriate frames to try to essentially remove a person from housing. There are some serious incidents and persistent cases where this might be good in terms of being able to mitigate and manage that. And so that's why I'm not asking you to say this hotline out loud, because we don't want this to be treated like the Nextdoor app. But for the landlords and the property owners, this might actually be very helpful for them to
Yes.
be able to do that. And so if I heard you correctly, because I did have a question here that I was going to follow up on around the intensive housing case management initiative, which I hope
At
is what we're talking
1.7,
about.
yes.
All right. That you guys said in February you're working to select a vendor, and then you said Community Connections.
Community
a
Connection is
provider.
a vendor.
Technically in March, started in March.
Okay. And there's funding in FY26 to continue this for another year?
Yes.
And if I might, council member, I met with several property owners recently, with the mayor and other team members from other agencies. And we did share the fact that we do have a hotline, and there were members of the Apartment Building Association there, and we should ask them to share it with their colleagues also. And then we are doing the same thing as we are meeting with various property owners.
Okay, great. Now we do see a line in the spreadsheet that we think is for this, but it says TBD. So we're gonna work with Adrian and folks just to confirm, because when we see TBD, I'm like, oh, maybe that's not free money, but money available. So I do want to lock this in, because this has been something that has been a priority in terms of the community for a very long time. Let me just go to community residential facilities really quickly. So according to the Office of DC Long-Term Care Ombudsman, there's been a 30% decline in the number of CRFs over the past 9 years, and that in 2025. 4 homes have already closed, 4 more are in the process of closing, and that we don't have enough beds in the district to accommodate the residents who are already at these existing properties. So let me ask this two-part question. First, for the individuals who were in the homes that have already closed this year or in the process of closing, what are we doing in terms of supporting them and finding new placement? And the second question is, how do we stop the bleeding?
Dr.
Yeah,
Badger,
and we
may I,
can
or do you want me
respond.
to
Go
start?
ahead. You can
Okay.
respond to both of those.
Unequivocally, obviously, this has been an ongoing problem. CRF homes close for various reasons. The owners get old, or they die, or they're no longer interested in providing that service. Variety of reasons. Sometimes there's an incident and the house is no longer safe, doesn't meet certification for whatever reason, or they selectively choose to move away from that business and no longer provide that service, because these are all private property owners. No matter the circumstances, we have a very rigid, clear-cut written policy that says, because they're contractually obligated to DBH, the closure cannot occur officially until every resident is properly placed in another home of their choice based on their level of care, because there are different levels of care. So we're not going to move somebody from a severe level of care to a lower level of care just because there's a bed available. So very rigid, managed by an aggressive, fully staffed team on our part. So no one has ever happened, it's never occurred where because of a closure, somebody becomes unhoused or goes to a shelter or doesn't have a place to go. And it's tied to their needs. So the continuity continues and occurs. A couple of other points. I've actually looked up the numbers. There's a difference between total number of beds available that we had at one time and the need. It's different. So you could view the first issue as capacity issue, and the second as a need. In the last 5 years, there's been a decrease in the number of beds we had available from 6 in the last 5 years, 631 to 527 currently. That's a 16% decrease. Okay, at the same time, so a bunch of beds went offline. We've added 71 additional slots. Okay, so it's a dynamic process. But as I said, when beds close, when houses close, everybody gets a home at the same level. Everybody. So then the question is, what's the need out there? Okay. And we're working very aggressively. We've had 4 solicitations this year to find additional new providers, operators. When one operator wants to go offline, we work with the other operators to see if somebody has the means and interest to take over that home, to purchase the home and provide that service. And we have 2 providers that from the recent solicitations that are coming on board, new providers bringing on board 12 additional beds above. So I said,
You have 527.
plus, yeah,
Plus 12.
12 additional, like immediately as soon as they're certified and contracted, and 40 committed, 40 by September. So that's 40 plus 12, so that's 52. So it's a real dynamic process. And the whole, again, remember the CRF process is managed by, primarily by the CSAs. So we've been able to meet the demand. So there are no people waiting, that have been identified as having a need that we're not serving today. We're being very aggressive to try to ensure that we stay ahead of the need so that we come as close to that previous capacity that I mentioned earlier.
Right.
Okay.
And no one has lost their placement. Nobody is on the street. Nobody has
in
lost their
the
placement.
in the shuffle or
That's
transition
correct.
away.
No one has lost their
Yes,
placement.
absolutely. Yes.
Is there a protocol beyond you have to be able to find a placement for somebody else? One of the things from the Office of Long-Term Care Ombudsman has been about clients losing belongings in the move.
I've not heard that. I mean, we work with them, by the way. We meet with them
Yeah.
regularly.
Okay.
In fact, I think we met with them last week proactively about the process that,
Yep.
we've just talked about. And they're updating them and briefing them about the plans and to ensure that the residents are properly notified. Basically,
Okay.
that we're doing our job and we're meeting their needs. I've not heard through those meetings that there was an issue with people losing belongings in the process.
Okay. I want to sort of go back, but sort of change scope just a hair. So, the FY26 proposed budget is proposing some changes on Medicaid. Let's put that to the side because I feel like we have a knock on wood plan there that we hope CMS will work out for us. The other thing we haven't talked about is Alliance, which is a completely different kit and caboodle. I mean, what we've had conversations with the primary care providers about Alliance. I don't believe Healthcare Finances has similar conversations specifically with the behavioral health providers about the transition on Alliance. And so what conversations, Dr. Bazran, have you been having with those folks? Because unlike Medicaid, where, yep, you're going to see some reductions. Yes, there's going to be a transition. Alliance is stepping down to, over time. There's not a plan to replace that, nor is there a plan to replace those services.
Well, actually, at our provider meeting on Thursday, the Medicaid director and I actually spoke with the providers around this particular issue and the fact that there most likely will be a change in eligibility
Right.
if certain factors occur. And in that instance, we will follow DHCF's lead in terms of how that population of focus is addressed.
Okay. Do we have any providers for whom their caseload is, right, on the primary care side, right? I have clinics, FQHCs for whom a hit on Alliance is a hit. They basically, that is their patient population. Do we have that similarly on the, excuse me, behavioral health side?
Yes, we do.
We do. We have La Clinica.
Okay.
And we
Pueblo.
have Neighbors Consejo.
Neighbors can say both of those two.
Okay. All right. Hold on one second. There. Okay. All right. Oh, hold on one second. Okay. Are there any other inconsistencies or errors in the budget chapter that we need to address?
Not that I've identified right now.
Okay.
Yes.
All righty. Okay. Dr. Bazaran, is there anything you wanted to say in closing?
Our goal, here again, is to ensure that quality care is offered to the people we serve. And we really are very, very, we really are moving towards whole person care. And we also want to really ensure that people get clinical care. And so we want to move to a more clinically focused model of care.
Okay, thank you so much. So this concludes my questioning for today. I had several council members who joined us, which is always good to see, members of the committee. I want to thank you and the DBH team for providing testimony, as well as the team from the mix of DBH and OCFO for being here. If we have some additional questions, my committee staff will reach out. There are a couple of things that we just need to get some follow-up
That's right.
clarification on. But this concludes today's hearing. So if anyone would like to submit testimony for the record, for DBH, it will remain open until Monday, June 13th. Until then, written testimony can be submitted via the council's hearing management system site, dccouncil.gov/hearings. The next budget hearing for the Committee on Health is scheduled for Thursday, June 5th at 10 a.m. in room 120. We will be hearing from the public witnesses regarding the proposed FY26 budgets for the department, no, not the department, the Deputy Mayor for Health and Human Services, the Department of Healthcare Finance, and the DC Health Benefit Exchange Authority. So if individuals are interested in signing up, you've got like 2 more days to sign up for that one. But the time is now 1:31 and this hearing is adjourned. Thank you, everyone.